हैव सेंड द रॉन्ग लिंक। या पॉल भी मैसेज कर रहा है। नैन्सी मैंने आपको वो किया है व्हाट्सएप।
मेल
करेक्ट।
भी be running that slide set for you, sir.
For whom? For me?
For you, the introductory slide.
5, 4,
As you speak, the slide will be running
3,
also.
2, 1. We are going live.
Okay, so we are all there. Okay.
Good evening to all of you. First of all, let me have the privilege to welcome the august audience who has been watching this wonderful program, and to a great collection of constellation of speakers all over nationally and internationally in front of you, in front of me. I welcome them all. Welcome you all to this a great masterclass series, which is one of its kind, which is basically sponsored by Shockwave US and Translumina India, which is trying to look into the various aspects, a very detailed look into the various aspects of coronary calcifications by some of those very distinguished faculty and expert panel and expert speakers panel. As I unveil this program to all of you, before that, I'd like to have a very sneak peek view of what the enterprise Translumina stands for. Basically a company with a global footprint in about more than 50 countries. And very proud to share with you that today, based on both polymer-based strategy or a polymer strategy, today we are one company in the world which has data of 10 years RCT. And with this journey, we have a new pit stop in form of ISAR Summit, which will be the first time a polymer-free everolimus eluting stent in for the patient in times to come. This is basically, if we look into our, basically we are at a various levels trying to be our presence in every field of intervention cardiologists, and this has all culminated into form of love and affections in form of various awards and accolades. We were recently awarded the most trusted healthcare partner in India. At the same time, our devices like Vivo ISAR has been now been considered as the most trusted and the most intelligent device of the year. These are nothing but a culminations of love and affections and trust supported by entire medical fraternity, nationally and globally both. Having said that, I would like to talk about today about Calcium Masterclass, and I would like to take this opportunity to hand over this session to the moderator of the evening, Dr. Rajneesh Kapoor, sir. Sir is a vice chairman at Medanta, the Medicity Gurgaon. Sir is a leading intervention cardiologist and a distinguished faculty member at various national and international meetings. Sir has been published over 100 articles, reviews, abstracts in various nationals and international journals. Very privileged to have you, sir, today. I would like to hand over this evening or this session to you to take this forward for a very exciting and interesting session for all the viewers and all the audience who would be watching. Thank you, sir. Over to you, sir.
Well, thank you. Thank you. And we are right here, and I'm really honored to be moderating this interesting session on calcium, breakage of calcium and how to handle calcium in coronaries, the master class on this. So it's a privilege and honor for me to be here and moderating this. As already mentioned, we have a very esteemed faculty for this who would be talking on very interesting cases, as well as going into the details of the data of lithotripsy and how to handle the calcium in coronaries. So we all know, once we handle highly calcified lesions in coronaries, that's a big challenge for all of us. At times we get stuck advancing our stents, and then at times, we are not able to dilate the lesions post stent with lot of under inflated stents. So I think that's one point also which derives the outcomes on the long term basis. So I'm thankful to Translumina for bringing the IVL to India, intravascular lithotripsy, the shock therapy, which we call, and which has really paved a way to deal with calcified coronaries in a different manner. So prior to that, we had a rota ablation, and we were frequently using rota ablation, but now we have two tools. So that we know, and we know that these two modalities can be selected even in calcified coronaries in different manners. So it's an intracoronary calcium, or it's the calcium on the circumference. So with regards to that, we can select. So that's what we are going to talk about in today's session. And I'm sure this is going to be highly productive for everybody who's attending this and who are here online attached to us. So without wasting time, I think I'll start the proceedings, which is going to be a very interesting and exciting session for all of us. So I'll get the things rolling. Our first speaker is a big international name, Dr. James Pratt. We all know that he's a very versatile interventional cardiologist who hails from St. George's Hospital, London. Dr. Pratt, welcome.
Thanks very much. Great pleasure to be here.
Yeah, so thank you. Thanks for being here, and thanks for taking out the time for this. It's going to be very interesting to listening to you, your comments, how to deal with this. And I'm sure you are presenting some of very exciting cases on this, a combination of devices to be used for calcium in coronaries. So Dr. Spratt is a professor of cardiology at St. George's University of London. He's globally recognized expert in complex coronary disease, and quite an innovative stuff he has done, in his career. Professor Spratt is a recognized expert and has published numerous research articles and books in this area. So once again, welcome to you, and I give the field to you, over to you for your presentation. And he's presenting on high-risk rota shock. So I'm sure it's going to be really interesting and exciting to go through his presentation. Over to you, Dr. Spratt.
Brilliant. Thank you very much for that kind introduction. A big thanks to Translumina and Shockwave Medical for the invitation as well. This area is a really exciting area, and I'm sure the audience is going to benefit from this webinar series, and a real privilege on my side to collaborate with a connection of Indian luminaries in the field. It really is a real, really enjoyable experience to interact with people to talk about what's happening in cardiology, and particularly within the field of calcium modification. For the audience, I would also direct them to Wonder Medical, where there's also significant material under the title of Calcium Masterclass, with a collection of live cases and lectures, and that's really worth having a look at. So I really wanted to give you, the audience, a flavor of what can be done with this new technology, and I've entitled this case Rotatripsy. As you'll see, it's a complex intervention which shows what you can do now with this new technology. So the patient is an elderly lady, so in her 80s, very small and frail, so not a good surgical candidate, who came in with an acute coronary syndrome, who's already had problems in the past with ischemic heart disease and very poor ejection fraction, so an ejection fraction of 20%, with some residual viability in the anterior wall, no real viability in the right coronary artery, and a degree of renal impairment. So already the treatment options are limited. Her size is such that LV support really couldn't be considered because she was too small. She certainly wasn't a surgical candidate, and she was a high-risk PCI candidate. So I'm going to take you through her angiogram and her treatment strategy. So here you've got an iliocaudal projection on the left. You'll see throughout this presentation that will represent the angiogram schematically on the right, showing a calcified proximal circumflex coronary artery, quite tortuous, with a heavily calcified left main stem and proximal LED calcification, this caudal projection. The working view for the LED is this cranial projection, AP cranial, and you can see the heavily calcified segment of the LED. So very, very long, heavily diseased area, critically stenosed, particularly at the level of the second diagonal branch. And our plan here was to do complete revascularization of the left side of disease. If you remember from the start, the right coronary artery is supplying non-viable myocardium. So we're trying to treat the LED initially. We can see that calcium is going to be our enemy in this case. So calcium modification is really the key focus in this case. Then treat the circumflex back into left main and complete the bifurcation with a two-stent strategy. I really don't want to use much contrast because of the recent acute kidney injury and the chronic renal impairment. So first of all, we deliver a rotofloppy wire. You can see we're using CTO techniques here. So a microcaster and a workhorse wire is delivered to the distal LED. This is then exchanged for a rotofloppy wire. And we perform rotational atherectomy over that particularly critically stenosed area in the mid-LED with a 1.5 millimeter burr. Other points worth noting at this juncture is that the guide is 7 French. So just going back a second. So you can see a 7 French guide, 1.5 millimeter rotor-burr. And then we go back in with the microcaster and swap out the rotor wire for a workhorse wire. At this point here, what we want to understand is what has rotational atherectomy done? Has it restored the vascular compliance, or is there still an issue here? And I think this is an area where previously, prior to the introduction of intravascular lithotripsy, or shockwave as we call it, we really were running out of options. All we could do was increase the size of the burr. And unfortunately, we know that there is a relationship between the size of the burr and the risk of complications. And let's not forget, this is a very small lady, less than 60 kilograms, with severe renal impairment and severe left ventricular dysfunction. And we really don't want to get no reflow in this dominant territory for her, the left anterior descending coronary artery. So you can see that we've gone up with this balloon on the left side of the screen in the angiogram, and that's failed to expand. So this is a semi-compliant balloon, failed to expand. And also a 30 millimeter NC balloon at high pressure has also failed to expand. So despite being able to pass the balloons down, they've been unsuccessful to restore vascular compliance. So we choose a 3 millimeter shockwave balloon. The 3 millimeter balloon is chosen due to the IVUS guidance here. And crucially, we inflate this balloon at only 4 atmospheric pressures. And we perform shockwave or lithotripsy to that area. You can see on the bottom left of the screen that this results in spontaneous capture of the ventricle. We call these shock topics, and that's synchronous with the delivery of the shock waves. And along with that, we get excellent expansion of the balloon therapy. So the key component at this time is to check that you've got A, balloon expansion, and B, evidence of fractures on intravascular imaging. So once we've done that, then we want to ensure that this next step of the procedure is as efficient as possible. So here we've used a 6 French guide extension. That's a specific choice because of the risk of ischemia and this fragile lady at high risk. So it's a 7 French guide, but a 6 French guide extension. And actually that is a particular concern if you're not aware of it. If you use a guide extension that's sized to the same size of the caster, the risk of the stent interaction at the back end of that guide extension is low. But when you use a smaller guide extension inside a bigger guide caster, there's about a 20% risk of the stent having a problem at the back end. So you have to be aware of that. And you can see that kind of schematic at the bottom left of the screen. that it basically leaves space for which the stent can interact the back end of the guide extension. But the role of the guide extension at this point is to circumnavigate that calcific area at the proximal and to minimize the risk of any stent damage. So once we've delivered this long stent, we can remove the guide extension back into the guide to restore the hemodynamic pressures and to deploy this stent, which is a very long stent deployed at nominal pressure. Now, the other key component at this stage is to understand that if you're putting in a 48 millimeter stent, it may well be sized well to the distal vessel, but it's never going to be sized well to the proximal vessel. So we call that vessel discordance, and it just simply means that the distal end of the stent is smaller than the proximal end of the stent. And of course, we know that, but there are two major points of risk here. The first point of risk is that if you do not perform proximal optimization to the proximal edge of the stent, you're going to leave the stent malapposed. But perhaps even more importantly than that, the risk if you're going to implant a second stent, the risk of crushing the front end of the first stent, which we call longitudinal stent deformation, is very high in the context of stent malapposition. So a key component is going to be proximal optimization of the stent. And this next step is extremely important. So what we want to do is deploy that stent, this next stent, without damaging the first edge of the stent. And the best way to do that is to use a balloon to reinsert the guide extension inside the first stent. So the balloon centers the guide extension, and when the balloon is deflated, the guide extension can be advanced so it's within the first stent. And that means that the risk of longitudinal stent deformation is very low. And that allows us to implant the second stent, this 3.0 23 millimeter stent, positioned with the use of this guide extension. And that's proximally optimized with an NC balloon. And again, distal optimization, again, with a further non-compliant balloon. At this juncture, we need to understand what the stent looks like. We don't need to do this. We don't need to perform an angiogram really at this point. We just need to make sure that the minimal stent area is above 4.5 millimeters squared, because we know that's really important when it comes to long-term risk of stent failure. And we need to ensure that there's no evidence of trauma to the distal vessel in the form of distal dissection. And if you think of this IVUS image in terms of systematically understanding what you're trying to achieve at the proximal end, that's the right of this schematic picture, you're wanting to minimize the risk of malapposition. The MSA is the key component that will determine the risk of long-term stent failure. So you want that to be as big as possible. And at the distal end of the stent, you want to make sure there's not any trauma in the vessel. Now, this is a small vessel in a small, frail lady. So the risk of trauma is perhaps higher than it would be in a larger patient with a lower plaque burden. But you can see in the bottom left of the screen, the distal vessel, although it's small, there doesn't seem to be any dissection there. The distal stent appears to be well opposed and well expanded. It's spherical. The minimum stent area there is also looking very respectable, and the proximal reference area is appropriately dilated, and there's no evidence of malapposition. So that's our first stage of the revascularization, is perhaps the highest risk stage that we've treated the LAD. We can see that stent is well expanded. There's still disease proximal to that LAD stent, but what we plan to do is to treat the circumflex first, then stent back into the left main, then pot the left main, proximally optimize that left main stent, recross into the LAD, and complete the clot by implanting the stent from left main to LAD before treating the bifurcation. So we wire the circumflex. And because it's so tortuous and calcified, we actually can't deliver the IVUS into the circumflex. And that's really telling us that this vessel is really non-compliant, it's really stiff, and we're actually even going to have to balloon before we can even deliver an IVUS. So pragmatically, we predilate with a 3.0 NC balloon. And that actually expands pretty well. So there's not going to be a need of additional intravascular lithotripsy in this vessel. And again, the proximal vessel, it expands well with a non-compliant balloon. So if it expands well with a non-compliant balloon, we're not going to need further expansion with lithotripsy here. And then we deliver a 3023 millimeter stent, again using the guide extension, and deploy that at 12 atmospheres. And you can see that stent extends from the left main into the proximal circumflex coronary artery. And again, getting back to that other key point, what we need to do here is proximally optimize that left main stent. So we've used a 4.5 millimeter balloon, a short 4.5 millimeter balloon. And before we do that, we remove the wire in the LED to avoid proximal compression of that stent. So this again is a key component. If you look at the schematic on the bottom right of the screen, you can see that here, if you deploy that stent in the circumflex and there's a jailed wire in the LED, you need to be careful that when you pull that jailed wire back, it doesn't pull the guide forward and potentially crush that stent. So there are two key factors which will reduce that risk. One is making sure that that stent is proximally optimized, in other words, expanded, it's opposed against the vessel wall, and there's less of a target for the guide to kind of abut it. And secondly, to be very aware that when you're bringing the wire back, that you could potentially bring the guide forward and cause damage to it. So that this pot is an extremely key component of any bifurcation treatment. So now we need to rewire the LED. So we rewire the LED with a workhorse wire and do that, ensuring that we haven't got any abluminal wire crossing. So we don't want to cross outside the circumflex. And again, the use of the proximal optimization minimizes that risk, and wire the distal LED. So the next stage is to recross into the LED. And actually a good technique here is that you can place a balloon in the circumflex and use that as an anchor. So if you're struggling to cross from left main to LED, your balloon in your circumflex will act as an anchor and increase your push force. So again, here we post-dilate the stent in the circumflex. We can again use the balloon in the LED as a way of enabling delivery of the balloon in the circumflex. So each of these balloons can in turn act as an anchor to deliver treatment into the other artery. It's again, before we finish the clot, what we need to ensure is that we post-dilated the stent in the circumflex. You can see a 3.5 millimeter balloon is used in the circumflex to ensure proper expansion. And now we want to deliver the stent through the struts from the left main into the LED. And again, you see here, we can use a balloon anchor in the circumflex to deliver this stent from LED, from left main into LED. And that enables us to complete the clot. Now at this stage, we've got the first stage of the clot is from circumflex to left main. The second stage is from left main to LED. Now we have to recross into the circumflex and finish with a kissing balloon inflation. So once again, we can use this reverse anchor technique by inflating a balloon in the LED and using that as a way of delivering the balloon into the circumflex again across the struts. And then it's sequential post-dilatation, high to the LED, then high to the circumflex, and then high pressure in both vessels with two 3.5 NC balloons. And then final high pressure balloon inflation to the mid-left anterior descending coronary artery. So this is what we've done in the angiogram. We've recrossed the circumflex stents, we've post-dilated, and we've kissed in both. Again, high pressure inflation, the distal LED, and then we finish with an OCT. And remember, this lady had renal impairment, so we didn't want to give her too high a contrast load, but we finished with an OCT because of the superiority of OCT in determining a proper stent expansion. So again, very interestingly, within the LED, you can see these fractures in that top image in the here. These are calcium fractures that you can see behind the stent. You can see that there's a bit of malapposition here. So you can see just a bit of minor malapposition in the proximal LED, which we can correct with a larger balloon inflation. And you've got an MSA, a minimum stent area of 4.2. Remember, this is quite a small lady, and the stent goes into the distal vessel. But so perhaps more interestingly, there's 91% stent expansion compared to the distal reference area. So really, the optimal MSA would only be about 4.3 anyway. So very good stent expansion given the calcific disease that we were dealing with. So I would say in summary that the introduction of lithotripsy and advanced calcium modification therapy is really giving these very high risk patients options where they didn't have options before. If you remember from the start, this is an elderly, frail lady with significant renal impairment and severely impaired left ventricular function. She had limited other options, and image-guided calcium modification with both rotational atherectomy techniques, which we're all very familiar with. I know in India is a real field of expertise with rotational atherectomy, but I think this is a great case to show what it's good at. So it's very good at dealing with high-grade disease, which you can't pass a balloon down, and what it's less good at, which is dealing with deep wall calcium. The combination of the two give this lady a fantastic result. And because of a renal impairment, even with the use of an OCT run at the end, we used less than 100 mils of contrast, and the stents were optimized and assessed by OCT. And the artery, of course, was initially assessed by intravascular imaging in the form of IVUS. So many thanks for your attention, and very happy to take questions based in this case and any other points of interest.
Yeah, so Dr. Spratt, this was a very exciting case shown by you, and really handled nicely and in a good way. So few points, I think you showed, where the combination works, Rota plus IVL both. So that is one point. And then the extension catheters usage, both, you have shown it very well. I just wish to know that have you thought of doing the micro culot, mini culot, rather than a full culot?
Yeah, I mean, I guess the rationale to do that would be to minimize the degree of stent overlap. So I think that's more important when the vessels are small. But if you're doing the clot in the left main, we were using 5 millimeter balloons proximally. So the stent diameter is very large in the left main, and the impact of these new generation stents, because the strut thickness is so thin, is pretty minimal. But I mean, the point you're making is a reasonable point, that you really want to minimize the overlap within a clot, and I think that principle is fine. The flip side of that is that when you're proximally optimizing the stent, you want enough of the stent back that you can expand it properly, and I think that's the key component of a clot. And I think in smaller bifurcations, you want to minimize the amount of stent full stop. In larger bifurcations, you've got a little bit more leeway, and the left main, of course, is the largest bifurcation we ever work with. So I think in this situation, actually ensuring that MSA is high enough is the key value here. And I think actually if you use double overlap in the left main, it rarely makes a significant difference as long as you prepare the vessel properly.
Yeah, so all other steps were spectacular and incredible. You managed it really well. Almost it was a very, very complex case, starting from a long stents, calcified curves, and then left main bifurcation created. Wonderful, wonderful. Anybody wants to add on to this thing? Any of our co-speakers? Well, in that case, thanks, Dr. Spratt. It was really wonderful having you, and you showed us the real essence of, how to deal with calcified coronaries, especially with the curved calcified coronaries. This was really exciting. Thank you.
Well, the thing is that case, I know when I see such fantastic cases, I'm sure I can see lots of old friends on the gallery here, but I know every time I tune in to one of your fantastic educational events, I'm always very impressed by the complexity of cases. And I thought this lady's case is very typical to some of the Indian disease you do see, sort of diffuse calcific disease, small ladies, small vessels, not that easy to get a good result in it. So hopefully that'll be in tune with the other fantastic cases I'm sure we'll hear soon.
Yeah, but I tell you, we find this type of disease in India much more frequently as seen in the Western world. You know, the small vessels, the calcified vessels, curves,
exactly,
and all that, you know, what not, you know, we find all the complex scenarios with the small vessels, especially in India more.
Exactly.
Yeah.
James, Dr. Hajra here. I really enjoyed your classes on Wonder Medical and Optima. I learned my tips and tricks of lithotripsy from your classes. Thanks for that. So my question to you, can you give any real life experience of equivalence of IVL shocks? Giving some examples like you have done in eggshells to start with, Jihad Ali has demonstrated. Can you give some kind of real life experience of equivalence of IVL shock, pressure, effect?
Do you mean in terms of what it's equivalent to with respect to balloon inflation, or do you mean dose effect?
Right. Any corollary or any examples in real life?
Yeah. So the dose equivalence in terms of the dose effect of IVL is, you know, I think we need to do more work on that. So I think at the moment what we have is a sort of test and check type way of working. So we do the IVL, we look at the imaging, and we see, do we see fractures? And we use fractures as a surrogate of restoration of vessel compliance. But we don't really have a good way of looking at the vessel beforehand and saying that's going to take 40 shocks or 50 shocks or 60 shocks. At the moment, that's all very, it's not very empirical. It's all very experiential. We see what works. If it doesn't work that time, we try something slightly different. So I think the problem we're having here is that we're using anatomical markers as a surrogate for physiological variables. So the physiological variable we want to understand is vascular compliance. The anatomical surrogate for that is calcium under imaging or under angiography. So those two things aren't quite equivalent. You know, we don't know how much calcium translates to what reduction in compliance. And actually, it gets very complex the less concentric it gets. You know, actually eccentric calcium, sometimes it's very difficult to know what difference it makes to vascular compliance. So I'm not sure how helpful an answer that is, but I think the best way that we have of managing it at the moment is that we use balloon expansion as a kind of surrogate tool. So, and because the balloon expansion is so low with lithotripsy, it's only 4 atmospheres. If you're getting adequate balloon expansion at 4 atmospheres, you know you've almost certainly got restoration of vascular compliance. But actually, realistically, what we'd really need to do is actually measure vascular compliance, which we don't really have a method of doing at the moment. So that imaging acts as that kind of reassurance, because of course we all know that it's too late once you put a stent in. If you put a stent in and you haven't got it right, it's quite difficult to get it right afterwards. So you have to get it right before the stent goes in.
I think
so James.
Yeah.
Hi, how are you, James? I have a very important observation from here on. You see, much of the bench testing data was related to a believing that we would be treating concentric calcified lesions and so on and so forth. But real life use of IVL is totally different. We've got long lesions, we've got eccentric lesions, we've got heavily calcified eccentricity, we've got irregular distribution of lesions. We also have, for example, if we use a single IVL, and I didn't see your case completely, but you size it to the distal vessel, you actually end up being undersized to the proximal vessel. And you haven't got enough of calcium the calcium proximally may not be as the IVL may not be as effective. It's undersized. So I think now we need more bench testing data on more real life cases, calcified nodules. What happens is eccentric calcification. How many shocks do you actually need? Maybe we should be moving to probably a non-compliant balloon rather than a compliant balloon with IVL, and saying that, okay, we'll give IVL and then just go up to 12, 14, 15 atmospheres and just be happy with the fact that we've actually got no residual stenosis left, rather than fall in a situation where we perhaps may have not done enough or adequate job. We never know when to take a second IVL, and across the world, by the way, a second IVL is not a very easy commodity in terms of cost.
Very true. I think those are great points, Ashik. I mean, you're absolutely right that actually we don't really have a good way of understanding the dose response, and we're just trying and we're trying again. And you're absolutely right. That's much easier to understand the concentric calcium than it is eccentric calcium. And the analogy I would give, and this is a fairly terrible analogy, but bear with me. If you have a windscreen, a car windscreen, with the sticky bits that stop, you know, the windscreen shattering in two, that before the windscreen breaks, the biggest predictor of how compliant the windscreen is the glass. Now, after the glass breaks, it's actually the stretchy bits that has the biggest predictor of how compliant the windscreen is, because they stop it, the glass going everywhere. And it's a bit like how calcium behaves in a vessel. So if it's in a single sheet, then a single sheet of calcium, concentric sheet, has a massive bearing on vascular compliance. But if it's broken up into tiny fragments, it has almost no bearing on vascular compliance. It's just that we don't know how many fragments it needs to be in, really. I think that's one of the questions. But maybe that one fracture isn't enough for very dense calcium. You need lots of fractures.
Yeah.
So the good thing is we're talking about these problems, and I think that's going to be the start of getting the answer. But I do think from a Shockwave perspective, we probably need to see the bench data and understand it, you know, a little bit more, so we can start to get towards a dose response. Because as you say, you know, one Shockwave balloon, you want to get the most out of it that you can and get the best outcome for the patient. And at the moment, it's not quite guesswork, but it's not far off.
Yeah, so I think it was a very good example you have given about the windscreen. Just want to add last point, and then we'll move on to the next one. Imaging either IVUS or OCT prior to using a Shockwave balloon is also very essential and very important, because yesterday only I was doing a case, and initially it was looking 2.5 vessel on angiography. So I initially thought to take a 2.5 Shockwave balloon, but after doing IVUS, it was actually a 3. So I turned on to, take a 3 millimeter balloon of Shockwave balloon. So that time, so this discrepancy is there, we know many times, and doing imaging prior and seeing the vessel size accurately is another key factor of using an appropriate size balloon. That is also very important.
Yeah, I totally agree. I think you're absolutely 100% right that imaging is absolutely critical here. Not only just to see when you need these kinds of calcium modification, but also to see have they worked, and also to see is your stent optimized. So you're absolutely right. You can't do these complex cases and just cross your fingers and hope for the best. We have the technology to support optimal outcomes. We've got to use it. So you're absolutely right.
Dr. Spratt, thank you once again, and be here. I'm sure you presented a complex case from UK, and we are equally in store what Dr. Seth is going to present next. So I think it must be more challenging and more complex, because he's the name who's known for all this stuff. So next speaker, I would introduce Dr. Seth. Dr. Ashok Seth, we all know. He's quite loved for his wonderful orations. He's known to the whole country and internationally. He has mentored scores of cardiologists, and he has pioneered many new techniques in India. So he's a chairman of Fortis Escorts Heart Institute, New Delhi. He's a president of APSIC and president Cardiological Society of India, and past vice president Asia Pacific Society of Cardiology. And we all know he has been awarded Padma Shri and Padma Bhushan by Indian government. So Dr. Said, welcome to the forum.
Thank you, Rajneesh. Wonderful to see you all. And of course, James presented a tremendous case. And what great illustrations, James. That's what Hazra was saying, that when we look at Wonder and of course Optima, the slides are just fantastic. And we probably need to learn that from whatever graphics that you create. I'm going to actually talk about some of the very complex cases, but I have a case in a box, 20 minutes case in a box. But you learn less from a case in a box because we actually interacting with very experienced interventional cardiologists across here. And therefore, I think we learn from a spectrum of cases, and I therefore thought about it, whether to show in a case in a box, but then to show 4 or 5 cases where we learned things, and they were different and unique, and we saw things which were different. So I think I'm going to therefore shifted my whole stance to saying, let me present cases and talk you through that and talk you through the thought processes, and maybe also have an interactive discussion at the end. So I'm going to share my screen and go on to the 5 cases that I selected out of now close to a near 100 IVL usage. So let's just get on with the cases. I still believe that IVL is a great, tremendous tool. I mean, there's no question about that there's ease of use. It requires less of a learning curve than other devices that we have in our armamentarium, and perhaps has the lowest complication rates. Having said that, you just saw James Pratt's case, as well as others will show you, that there's device synergy here. When we deal with complex, severely calcified lesion in the real world, it's not a one tool option. Multiple devices may need to be used to finally get the best result for the patient. And that's well understandable. Of course, we understand that IVL has been one of the greatest additions to our armamentarium in the recent times of dealing with calcified lesions. And we introduced it into the country a year and a half ago, in January of 2020 at the CHIP CTO India meeting. And since then, of course, we've actually, as you know, embarked on the Shock India registry. We've had the meeting of the investigators. 1,000 patients at 50 centers are going to be enrolled in the study, which is expected to start with the first patient enrollment in exactly a month's time, as the protocol has been frozen and various ethics committees of various centers are now looking at the protocol. So I'm privileged to be the principal investigator of the study with Jonathan Hill, with a co-PI of my great colleagues, well-renowned colleagues of Dr. Bell and Dr. Sandra. Well, some of the tricks and tips of around IVL are important. We understand, we understood that from the real world usage rather than from the CAD data. And I must say that you must look at this editorial of mine in recent times, From Rock to Metal. When we talk about balloon to artery ratio, we must remember that when we size it to a distal vessel, we're not 1:1 in a long proximal calcified vessel. It has to be clearly understood. We're undersized to the proximal vessel. I just said that. And you may end up needing a second IVL balloon because you may be ineffective in dealing with a proximal calcium of a 3 balloon in a 3.5 millimeter vessel. This is a device. We must remember that the device we have till now is thinner balloon material. If you force it across calcified lesions, if you actually force it, if you start firing pulses into the a device with a device which is not expanded, you could get the contact of the emitter on the balloon material, leading to rupture or leak of the balloon. So it's important in my mind to dilate the lesion with a 2 millimeter balloon, even a 2.5 millimeter balloon, to avoid emission of the balloon, emission of the emission of the pulse on the balloon material itself. It also gets you to image prior to dealing with the lesion, which is very important as well. So I don't mind a 2 and a 2.5. It's not an ego battle between the lesion and the device. You don't need to try and force this device across a severely, heavily, highly stenosed calcified lesion just to believe that you don't want device synergy and the fact that you want the device to act alone. We well understand 4 atmospheres, let it expand before activating the pulses, give the time to for the artery to breathe in between pulses, but it also helps to decrease the temperature of the contrast saline material, which gets heated up when the emitters fire on that. So it also gets the contrast back into the indeflator and therefore cools it off as you push it back in again into the balloon. So the cycle, the breathing time is important. We need more cycles. We don't understand that. How many cycles do we need over eccentric and nodocalcified till the balloon expanded? And in some situations, an eccentric indentation on the balloon may still be noted at the end of the 8 cycles. Do you really need more? How many cycles would you need to get remove that? Are still unanswered questions, and that's what we were discussing in the previous discussion with Dr. Spratt. And of course, we don't want to exceed pressures beyond. So let's see where we actually go from here in the real life cases with the real world usage of this device in the best possible manner. So we have the 75-year-old male. He's primary PCI at another center. This is the index procedure at the other center. You can see RCA is included. This is from the radial route. The wire does cross across, inability to cross balloon, and a microcatheter to change that wire. So he's stuck, and you can see that heavily calcified lesion right at that point of the occlusion. Various attempts to finally, there's a balloon which is across. That's at 18 atmospheres. The balloon does not open up. It was only a compliant balloon which could be got through. You can now see that there are 2 wires down for a better support. And then a non-compliant balloon would not go across. And after, I think, a 2.5 hour of a struggle, the procedure was abandoned. The patient was electively sent to me 2 days after this failed procedure. And so it was now 5 days later that I actually had this patient from the operator himself. There was thrombus in this vessel, as you can actually see, the high-grade stenosis, the really calcified is fairly visual here. And of course, got the guide in, it's an AL1, which is the right. We need support here. It takes an upward curve. We know that it is an undilatable lesion, and we know that we have to have a good guide catheter support. So I think those are the important aspects of any heavily calcified lesion. Good guide catheter support wires, guide extension catheters, and then never deal with the lesion and never implant a stent till the lesion is fully dilated in both orthogonal projections. I emphasize that, both orthogonal projections, because even as early as a month ago, I implanted a stent looking at one projection in which the IVL balloon was fully open. And after implantation of the stent, as I went to do a post-dilatation in the other projection, looking at the proximal edge, lo and behold, I had a 40% residual stenosis, even though the imaging prior to that stent implantation had shown fractures. Therefore, it depends upon where the fractures occur. If it occurs in the thinnest area and you have the deep, thick calcium still there, you would actually have an oval expansion, an elliptical expansion of the vessel, which would look totally undersized in one dimension compared to the other. Well, here it is finally. We have the situation of getting the wire across, of course, clearly guide extension, but unable to pass an OCT catheter across. But then, of course, we realize that this is going to be it's going to be concentric and deep calcification at that point. I think this is the right case for laser. You have thrombus there. You have an undilatable lesion, which is focal point. You actually then have another area which is still calcified, but filled with thrombus. And I think ideal would be, though rotational atherectomy of that focal lesion is possible, IVL gives the advantage of going through the whole thrombotic area of calcification as well as the long lesion length. So ELCA 3 passes going up on the fluency, and then followed by, that's after 3 runs of laser. And then I have a non-compliant balloon at that particular point where I have done a laser, and you can still see that the balloon is not expanded. Options, of course, are clearly IVL. So that's the OCT pre-analysis. You can actually see thick concentric calcification greater than 270 degrees close to 360-degree arc at that undilatable lesion site. Of course, there are areas of nodular calcification as well as thrombus down the vessel. So with that in mind, it is IVL, vessel is sized, it is 3.5 millimeter IVL. And then it takes 40 pulses, which is 4 cycles, to break this lesion. And it is now open, but you can still see that eccentricity even after 80 cycles and 80 pulses and 8 cycles on the medial side, which is of course the thickest part of the calcification. Post-IVL analysis shows adequate fractures, and that's what I do mean, that the adequate fractures would occur in the areas which are thinner calcification, even though the thicker calcification may get softened, to be able to give you adequate stent expansion. And by the way, while we talk about looking at these fractures, we must also remember in the CAD3 data that only 70% of the patients showed fractures of calcification. Of course, there could be microfractures, which is another mechanism in which way IVL works and gives adequate expansion of the stent. So it's a 4.38 drug-eluting stent, and I realized that I probably should have taken a 4 millimeter IVL rather than a 3.5 millimeter IVL. And of course, this is device synergy. You still have area of under expansion there. Go in with an OPN balloon at 4 millimeter. I'm sized now accurately. I know it's a 4 millimeter vessel, 35 atmospheres to that. Get rid of the eccentricity on that stent, and then post, and that's the final result on that lesion. A combination of laser and IVL, followed by an OPN ultra high pressure balloon, is what gives me the maximum MSAs in this vessel, gives me large lumens with symmetrical expansion, even in that area of eccentric, in that area of concentric heavy calcification with variable thickness around the concentricity. And then I would say that imaging helps to size the IVL appropriately and do an ultra high pressure dilatation. One interesting case about nodular calcium. We well realize that nodular calcium is our nemesis. There is no great device which actually deals with nodular calcification, but of course, if you have a guide wire bias, which you can decipher well on imaging, especially OCT, and if your guide wire bias is towards the nodular calcification, then rotational atherectomy or orbital atherectomy, which we don't have at the moment, but will be getting soon, would actually deal with the nodular calcium to an extent. And I also believe that that's equally important when you image. You know, Rajneesh raised the issue about prior imaging. I also do prior imaging for the basis of seeing my guide wire biases in heavily calcified eccentric lesions, because I believe that even though your balloon can be got across those lesions because they're not tight enough, rotational atherectomy could help you further by actually taking away some of that eccentric calcification because of guide wire biases, therefore giving you a better apposition of the IVL balloon, and therefore fracturing or being more effective to what is the eccentric calcium, because you've thinned off that eccentric calcification by rotational atherectomy because of guide wire biases. So I think it's an important aspect to keep in mind. And there are other occasions where I have repented I should have used rotational atherectomy for this very reason. So here's a nodular calcium, and let's look at this. And let's look at the mechanism of action of IVL in this sort of situation. This is done in another hospital on 10th August 2020, and this is a vein graft, old vein graft, calcified vein graft. It's a piggybacked, going to the LAD and going to the circumflex system, as you can see here. In fact, it was calcified to the extent that the operator had a problem in trying to get any device across it, including having finally got a better backup with an AL guide into the graft, and then still no balloons would cross. And I would compliment him for this expert procedure where he actually did rotational atherectomy of that calcified vein graft, as you can actually see here, and then implanted a stent, a 38 millimeter stent into it. But obviously, rotational atherectomy would not give adequate decalcification of the vessel, adequate compliance of this vessel. And there were areas of underdilatation, which he did try to open up as much as possible with non-compliant balloons, 3.5 at 22, 26 atmospheres, and they were still left with residual stenosis. He came to us a few months later. Of course, he had a restenosis. The restenosis was not in those underdilated areas, but there was this was an intimal hyperplasia. And you would see that a high-grade stenosis at the distal end of that stent here. There was another lesion left behind in the index procedure, which was distally. I dealt with that. And then, of course, had to deal with many areas of underdilatation. So here's what we have on the OCT pre. We have a calcified nodule. We have in a 3.5 millimeter or a larger vein graft, we have an area of 4.35 there. We have a better lumen areas more proximally, but then there are areas of neointimal hyperplasia at underdilated areas, which have not got yet to critical stenosis, but of course, critical stenosis was distally, where there was enough neointimal hyperplasia. I dilated all that, and then of course did a cutting balloon dilatation in all those areas of neointimal hyperplasia. And then of course, we knew that I had to use an IVL to get adequate expansion of the stent. And so here's a 3.5 millimeter IVL, with majority of the pulses being delivered at that nodule and the proximal area, which was restenosing and hadn't been dilated adequately. These are the two areas which had 60 of the pulses. The remaining, of course, had rest. So this is in the vein graft, and you see what's happening now. Fractures clearly, but this is what I love. At this time, we have now an area of 5.35 after the pulses are completed, and I'm getting fractures on either side of this calcified nodule that you actually see here. And that's behind the stent, by the way, because the stent now comes this way. While it's embedded at other places, this is where the stent comes, and I'm actually trying to see these fractures. And of course, OPN then and I know the sizing, so 3.5 OPN at 40 atmospheres. Now I'm getting dilatation, both of the stent as well as of those residual calcified areas, as you can actually see here. I think I've done that, completed it at 40 atmospheres, had finally mild residual stenosis, did a drug-eluting balloon across all that stent, which is what is now needed to give me the best possible results in the longer term. I have actually now expanded that graft very well and adequately. What is interesting is, and that's distally, so I'm happy now. Now, what I see is brilliant. Of course, I've got large areas, but at that nodule site, now I've expanded the stent to 8.96, close to 9 square millimeters. And you see the stent expansion in all those areas, now getting to 10 square millimeters. That is giving me comfort to say that this is the final adequate result. I have actually now done a cutting balloon for intimal hyperplasia. I've given IVL. And look at how now the calcium nodule's been flattened up and the stent has actually circumferentially expanded because I created fractures on either side of that nodule. And so really now got a circumferential expansion of the stent. And then followed by a drug-eluting balloon gives him the best possible chances of not coming back with a restenosis. This is an interesting case. And I think this is perhaps one of the most illustrative cases of CHIP that I've actually dealt with in recent times. A 78-year-old male recent anterior MI, then he had subsequent admissions with left ventricular failure at another hospital. His ejection fraction was 30%. He had severe triple vessel disease. This was an angiogram at another center. We did his PET scan for viability, and there was viability in all territories, and especially in the anterior territory where he'd had a recent infarction. He was treated with heart failure therapy, still a situation that he was least symptomatic. He was refused surgery by the surgeons for the sake of both diffuse vessel disease as well as LV dysfunction and heart failure. And we took him up, of course, for triple vessel revascularization with Impella. So here is his the right system, and you can see that's calcified. There's a high-grade stenosis in the proximal segment, thankfully nothing distally. His left system is bad. You can see that the OM, the circumflex is diseased, as is his whole of proximal LAD, distal LAD, and the LAD diagonal bifurcation as well. So this is taken up for a chip case. It was a live case. This is recorded. By the way, the recording was so long that it takes me time to put it into 20 minutes. So I'm going to talk you through it. So this is, I think, a good demonstration of a single access technique. And I think I'm just going to play this, a single access technique on an impeller. And this is, I'm demonstrating that I do it with a micropuncture needle. I hope, are you hearing the sound?
Everyone says fine, absolutely fine, splendid.
Nicely in. You can see I'm midway, but still parallel to the shaft. Take this out.
No, so you keep on describing your background sound.
There is a background sound to it. How to get the background sound, because it's much easier for you to listen to the background sound. Okay.
No, so you continue to comment. I mean.
Okay, then I'll continue to comment on this. So I use a micropuncture kit. I go on the outer quadrant. It is halfway between where the impeller is gone through and the outer surface in the diaphragm. It is only possible through a CP sheath, which is 14 French sheath. You can now have the microcatheter going in, goes nicely in on the side of the impeller. And you've got to be parallel to the shaft. You're midway, but you've got to be parallel to the shaft. You can't be angulated to the shaft, otherwise you have a problem in putting your sheath in. Now you can get an 014 wire, you can get an 018 wire, but you just have to, you 032 wire. But that's the one, I use a wire which comes with an impeller catheter. And you just double check in the fluoro that has gone up, and you're taking this micropuncture sheath out and now put a 7 French Pinnacle destination sheath. It's from a Teramo. You use a 45 centimeter sheath. In this case, it was a 65 centimeter. It's lubricated, it's hydrophilic, and it would go in, but you got to hold the impeller catheter, as you see here, impeller catheter, because if you don't hold in, it's going to be pushed. So it's almost like, so it's how you put the balloon in a rapid exchange balloon is when you hold on to the wire. Here you hold on to the impeller catheter in the same manner. Now, I did that pre-dilatation of the diaphragm with an 8 dilator so that the 7 French sheath goes in neatly. And now you see the sheath coming in. In this case, we had a 65 centimeter sheath because they didn't have 45 in the country. We need to make sure that Terumo, and since then Terumo started keeping 65 centimeter destination sheath for myself. If you use a 6 French sheath, by the way, you will get it completely through. But on many of these complex cases, 6F sheaths may be inadequate. So here we're looking at the impeller because it just moved a bit, and now I'm holding it again, and this is fine as I'm putting the sheath in. The last 10 centimeters of the sheath are not coated, and it therefore will stay out. So this is where you've got to put it more firmly, and you'll probably still have a 7 centimeter sitting out. But if you had a 6 French sheath in, then there's least chances of those sticking out a lot. But that therefore decreases the length of the equipment that you actually have in mind. So if you've got a very long patient, then you're going to have problems with that. And now you have that sheath into place. You have a single access, and everything is into place, and now you start functioning. Now we are in the vessel. So let me just take you through the case then. OCT did not cross, so we went in with a 2 millimeter compliant balloon, which partially crossed, and I dilated that vessel. But you can see that indentation, and even this balloon had a problem crossing. So then I went in with a 2 millimeter OPN balloon to again break the lesion, and therefore be able to analyze and have a look with an OCT. 35 millimeter constrained. Well, if it was constrained, anything which is constrained, think IVL. And I said, there's no point doing an OCT. Let me just go straight to an IVL. And therefore, again, the only reason would have been sizing of the vessel. Took a 2.5 millimeter IVL Another learnings, had I known that, had I done this run prior to the IVL, I would have known that it would be a 3 millimeter IVL rather than a 2.5 millimeter IVL. And here it is. You see that heavy calcification, you see circumferential calcification, you see deep calcification in that run. So that's very obvious. And I have fractures. Okay, 80 pulses delivered. And then 2.75 into 38 Zions expedition put in. OPN had residual stenosis and went back with an OPN at 3 millimeters of OPN and at 40 atmospheres. And an OCT demonstrated adequate expansion all the way of this vessel, right to both landing zones were great. Vessel, it was concentric expansion, good expansion in all directions, even at the most calcified and eccentric part. So I was happy with that. There's nothing to show you here. The patient was doing well on this and therefore go to the next side, decided to go to the circumflex, wanted to go to the OM as a second vessel, went to the distal circumflex, went in, and you can see I'm putting the stent in. This did not require rotational atherectomy. I've implanted a stent. Well, soon after that, there was hypertension, there was severe chest pain, there was drop in pressures, the impeller had to be turned max, there was slow flow all across. This was patient was having chest pain, and this is clearly air embolism. The air had gotten through wherever. It happens to all of us in these very complex procedures that we perform, and somewhere we miss the amount of air going in, and every vessel is occluded at this stage. Well, luckily, on impeller, we were able to support the patient. We did auto-perfusion. The impeller was supporting the patient, and we therefore, over the next 5 minutes, were able to restore flow. But had it not been for the impeller, this patient would not have actually been in resuscitation with cardiac arrest and resuscitation. Recovered over 5 minutes with auto-perfusion, and then proceeded to rotational atherectomy of the LAD. Therefore, didn't go to the OM and said, let's finish the job. This is now better to get on with the LAD and revascularize the LAD. That's the most important vessel. And of course, did a rotational atherectomy of the LAD. But remember, a month ago, this was a culprit vessel. So though there were areas of heavy calcification, slow flow occurred on the LAD with closure of the diagonal, again chest pain, and again EKG changes, some hypotension, but a writhing patient, as you can see. So well, we had to deal with this, again max the impeller, and therefore went ahead, infused nitroprusside distally, and dilated the diagonal, because now we had to do bifurcation stenting. So what was going to be a DK crush, of course, had to be transferred into a simpler technique of just a tap, which is fine. You do it simply. You don't want to make things too complex. Revascularization of the all vessels is very important. So again, a stent goes into the main LAD, followed by recrossing into the diagonal branch, balloon dilatation of the diagonal branch, a stent implantation in a tap manner to the diagonal branch, kissing balloon dilatation, followed by a good result to LAD diagonal and restoration of flow into a huge diagonal branch. Well, the proximal part, as you can see, heavily calcified. By the way, by this time, I've also dissected the left main, which was actually diseased, and you will see that flaps actually on the left main itself. So we know that we got to do so IVL comes in. This is a 3.5 IVL, and there's heavy eccentric calcification, and 80 pulses are delivered to that heavy eccentric calcification on the proximal LAD, as you can see, and into the left main. You can see that, and there's still, after 80 pulses, there's still eccentric residual calcification. So from lithotripsy, then to, okay, and then of course with a non-compliant balloon at 26 atmospheres. And stent is implanted. I still have some residual stenosis. I go in with a non-compliant balloon. I see some eccentricity, and I say, okay, I need to do a better job than that. And I go up with an OBL at 35 atmospheres, and I see eccentricity, and I go up with OPN at 40 atmospheres, and I actually, now the eccentricity is gone. And the eccentricity is gone, and I have a perforation of that vessel as well. So again, it gets you to the fact that imaging becomes essential at every step. There are no shortcuts, unfortunately, to whatever we do. every time we go up on ultra high pressures, we need to understand what we're doing. Are we actually having eccentric expansion or concentric expansion? Do we actually need to chase these eccentric lesions just because we believe we're looking at it in one view, but we may be having large lumens where we don't need to chase them? Okay, so again, we're anyway on Impella and there's a perforation. So 3.18 graft master is implanted into that vessel, dilated adequately. I take a 4 at 22 atmospheres and do a good job on that. And then that perforation seals. By the way, it doesn't seal with a 3.5 graft master at 20 atmospheres. It only seals up after we've dilated it with a 4 non-compliant balloon at 20 atmospheres. And that's not unusual of a graft master. These are 2 layers of stents with the PTFE in between. They need high pressures to be able to expand completely. And then, by the way, they also shorten by as much as 3 millimeters, and the membrane is within the edges of the stent. So we need to keep all those in mind. And of course, the second stent goes in across the left main and across the circumflex, and a final port is done. And then finally, we got a great result, and now the patient is looking good, and patient is stable, and we've revascularized large areas of this patient. And then we look at this with IVUS and know that we've had adequate expansion of but this is what I should have done prior to that high pressure implantation. I shouldn't have done it just at that particular time. So any shortcuts that we do in any of these patients lead us to more problems rather than solutions. And therefore, this patient's done fine. It's as you know, it's now a few months later that he actually walks 4 kilometers a day. His ejection fractions improved to 40%. We had large lumens. So I think that is, I think I should stop here. But just to tell you that, I think I just tell you my conclusions, because, here's a very interesting case though. But I think interest of time has to be always followed. And I think that, let me just take you to my last conclusion slide. And yeah, but I think the conclusion slide for me is very important. It conveys the messages, because like I just showed you, that these are complementary tools when you deal with complex severely calcified lesions in real life. So we have atherectomy, we have intravascular lithotripsy, we have ultra high pressure balloons in armamentarium. You just saw the judicious use and understanding of those, but those understandings need to come from imaging. Advanced algorithms are needed. I would have shown you just a case where nothing worked. Even an IVL failed to open up a lesion. Rotational atherectomy followed by ultra high pressure balloon failed to open up a lesion. Ultra high pressure balloons burst and could not open up the lesion. Neither could IVL open up the lesion. So we need to have advanced algorithms, which I do, by the way, of what happens if rotor burr and you burred for 5 minutes and it doesn't cross. What happens if IVL fails to break a lesion? I mean, that's also to be understood. And it's happened with me. Intravascular imaging is essential. And it's not just essential to plan out the case and to optimize results. More importantly, I believe it's important for the safety of the patients, because when you use multiple tools, including ultra high pressure balloons, you need to know exactly what you're doing. What is the next step? Are you sizing adequately? Have you got an adequate lumen? Are you just chasing a false shadow, or should you be tracing the lumens and the MSAs? I think those are the very important aspects of learning as you deal with these heavily calcified lesions with the armamentarium of tools that we have in our practice. Thank you very much for your attention.
Thank you, Dr. Said. That is wonderful. Since Rajneesh has left, I would request Dr. Kirti to have a comment of doing the first case anyway differently what Dr. Said has done. The first case of RCA, and James will comment on the second case and third case. First, Dr. Kirti, first case.
So I think the RCA, a marriage of calcium with thrombus is an ideal situation to kind of pull out the laser. And I think that was done appropriately. Uncrossable lesions is another great tool. So I'm not sure if that case was uncrossable, but if there was fluoroscopic calcium in an acute coronary syndrome and you expected it to be calcified adequately, you can see, but if you expect there to be a little bit of thrombus along with it, I think laser as an atherectomy tool, as your first tool, is fantastic. And we've got a few cases like that now. I do believe that the algorithm has to be simplified, because many a times we cannot be seduced by what we see on the image in terms of concentric calcium as an eccentric calcium, but it has to be a little more simplified, saying that you have to first find an unexpandable area by your normal NC balloon, which is probably the most cost-effective way to do it. And I think the most important aspect is to adequately size those balloons based on your imaging. So laser followed by imaging, size it, get your NC balloon to the right size, which is going to be the size of your destination stent in that segment. I think that's where the only problem arises in the LAD when it's diffusely diseased, like in James's case, where it's often a wonder as to, you have a landing zone of 2.5 millimeters and you've got 50 millimeters of the LAT to work on, and you have a choice of whether you need to take a 3.0 or a 3.5 or a 4.0 IVL. And I often think that, in the first year when we used IVL, we didn't know what to do. But now when we have an NC balloon, we take a 3.0, a 3.5 and a 4.0 NC balloon, and we identify those unexpanded areas and only open the appropriate IVL balloon for the unexpanded area. And sometimes we have to open two. And so, because I'm not sure if a undersized IVL really works in an oversized artery. And I really would love James' comment on that and Ashok's comment on that. But,
right. So
but it was a
saying...
beautifully done case, Ashok. Very dramatic, very exhaustive. And my question to you is, when you have so much happening in an artery, Ashok, do you wonder sometimes that we may have to have a shift in staff and shift in focus, because we can lose focus, we can get tired, we can be complete. I often feel that, and sometimes one of the reasons is I stage a procedures because I feel I go through fatigue in 1.5 or 2 hours. And so how do you manage that? Because you seem to have energy all the time.
It's an interesting question. I think, at that time, you don't feel the fatigue. I don't know. At that time, your adrenaline is high. And I always believe that, when you're doing a case and when you're going through step by step and you've got to keep the focus, it's only your adrenaline which is getting you to keep the focus beyond a particular time. And I think that you said right, beyond 2 hours, 2.5 hours, you start. If you actually see the fact that I took a shortcut of not imaging was only because of that fact that I'd actually gone through 2.5 hours.
Did you slap yourself on the knuckles?
Absolutely. And that again and again, I keep saying the same thing. Either you actually stage or you keep your concentrations high and do not take any shortcuts right till the time patient leaves your table. The moment you take a shortcut, I think it is not right, and you make more mistakes. And then you spend a much longer period of time trying to correct that mistake than you would have taken. So I think that's the emphasis, what you're saying and what I have to say to everybody. Never take a shortcut. Do exactly what you actually should be doing.
James, what do you think?
See the calcium, feel the calcium, palpate the calcium. James, do you think all the severe calciums are born equal? And second will be your commentary on the third case. In which way you could have done a different kind of approach in the third case?
Yeah, I mean, there's so much in there, Ashok. Great presentations as always. Just so many learning points. I particularly like that. I think it's those of us who are more experienced know that you don't put all your faith in any one thing. You realize they're complementary. Everything fits together. It's like putting a jigsaw together. No piece is more important than any other. So I thought that was great. I think getting back to the question about the apposition of the balloon, there is no question that lithotripsy does not work if it's not opposed to the vessel wall. So that's the key component of its effectiveness. So if there is malapposition, the balloon's undersized, you will get a massive diminution in effect. So that's absolutely critical point. I think, the point of expansion, when we use surrogates of expansion like balloons, particularly in the context of eccentric calcium, that's where the hazard lies. And that's where the perforation came from. Because what you're seeing when the balloon expands is overexpansion of adventitia on one side and no change to the calcium on the other. So you just tear the vessel at the point of juncture. And I think when you see concentric calcium, I'm never worried because I think the risk of concentric calcium is really low. The only risk is that you don't modify it. But the risk of perforation is extremely low because you're applying the same force in a concentric fashion. It's eccentric calcium where the hazard is, and you're making a conscious choice. What is the risk versus the reward? And the risk is the perforation, the reward is the MSA. So if you get a point where your MSA is, well, it's not as good as you might like it to be, but it's probably good enough, that's where the kind of real judgment comes in. But I think imaging gives you that option, Ashik, doesn't it? Where you have a look and you think it's eccentric. Maybe I should just, be discretion rather than valor here. But
Absolutely.
I also think you see a case like that, a tour de force like that, where the patient it's a surgically revascularization essentially. That it's a team-based approach, and I'm getting on to the whole fatigue issue. I think actually the more the team supports the imaging, the more the team supports the access, the less stress on any single operator. So I think actually we can learn from TABI in this. Like you're one of a team in TABI. PCI, it's always been about one person, really. We like to talk about ourselves a lot, don't we? So. But I think the way things are going, there's easy arteries and there's harder arteries. You can let your less experienced colleague do maybe the circs, the easy one, or the LEDs easy one, and you can do the hard one, and that way everybody actually wins from it as well. Ultimately, of course, the patient wins. But I just thought it was a great example of a mind that's constantly asking questions, Ashik, and we're all learning from the answers. So thank you for that.
Thank you.
Thank you.
And you're so right. It's teamwork. It's absolute teamwork.
Big salute and big thanks to Dr. Seth. And we'll move on to the third case, and Dr. Jamal, Dr. Sridhar, and Dr. Sunil will, let me phrase it out. Dr. Sunil will comment on the third case, and we have Dr. Kirti Punamiya, who is a senior intervention cardiologist at Bridge Candy Hospital, Mumbai. Over 30 years of experience. His area of special interest lies in chronic total occlusions, complex coronaries. He's a teacher. He's a great performer, and he's the interventional cardiologist in Indian subcontinent. They do a complex case of lithotripsy. This is very small introduction. He's much bigger than that, and thorough gentleman. And welcome, Kirti. And the comment will come from Sunil, Dr. Jamal, and Kasturi. Over to you, sir.
Thank you, Dr. Shed. Can I talk now or later on?
Later on.
Okay.
Later, Jamal. Once Kirti finishes his talk, you can give a comment.
Thank you.
So sorry, I'm going to try and make it brief because there's only so many things that one can learn in 1.5 hours, and I thought I'll just try to skip through my case. This is an 81-year-old who presented with acute coronary syndrome. His ejection fraction 6 months ago done was around 60%, and with this coronary syndrome dropped it down to 25. He had an NT-proBNP marker at 40,000. All his markers were raised. His creatinine is around 1.7. He's had chronic monocytic myeloleukemia with thrombocytosis. His platelet count was around 900,000. He's hypertensive and underwent a coronary angiography at a peripheral hospital, at another private hospital, was offered surgery, was a very high risk for surgery. The family turned it down, transferred to Bridge Candy Hospital. My next one of my slides are my IVUS runs, which are not incorporated in the video recording of this case. So this is a case from this Monday, and I'm going to try and see if I can do justice by switching between these two areas. If only I could stop sharing here and come on to the video. So can everybody see this video? This is the us getting the access. Typically, it's always almost an ultrasound guided access for this. We're identifying the femoral artery at the head by an ultrasonography. We get a simple access there. We do the same for the for the venous side as well. We've got an arterial 7 French, we've got a 6 French venous, and we go ahead with the case. And I'm going to show you what we have in a minute. So once we have our axis is right, this is our diagnostic angiography. Do let me know if you're not able to see something, but
at the moment it is
slowly.
Yeah.
Move.
You see
this is a
the
video
is not moving.
This is a video recording of this. Should I just skip this and just go on to the basic frames that I have?
Because the video is not moving, you may have to click this to start it.
I am, but this is the video they've sent me.
Right.
Of the recording. Okay, I have a backup to this, so let me play you the backup 1 minute. I'll take you to the actual case as it happened from my laptop. Yeah. Is that better?
Yep.
Yeah.
Yes.
Okay, so this is, I'm going to play it as is with everything going on as is. Let me just take it full format, full screen. Okay. So this is the left, we have a central line. We've got a noradrenaline infusion going on to maintain a blood pressure. We've corrected his hemoglobin in the last couple of days. And this is his coronary anatomy. He's got a left dominant circulation. He's got that distal left main, which is tapered. And it kind of ends up in this. This is probably the most informative view, if you can just dwell on it for a little bit. There's a circumflex, which is dominant, which is eccentrically compromised at its origin. There's a ramus arising, so a true trifurcation in that sense. A distal left main tapering, heavily calcified area, which goes all the way to the mid-LAD. And I almost have a no connection between these two. I'm not able to tell whether my entry point is at the bottom end or the top end of this artery. Once I've, so this is a quandary and a query for me as I go into this case. We do a left ventricular and diastolic pressure because we have the access to an impeller, and the left ventricular and diastolic pressure with all this noradrenaline and diuresis and correction of hemoglobin in the last 48 hours has brought his LVDP to around 15. For me, that is no use of impeller. I do not use impeller under the circumstances, so I go in with a 7 French guiding catheter. My first business is to get a wire into the LAD, and that was a bit of a struggle, trying to understand without closing that LAD. You can see I'm trying very hard to get there. I got a wire into the circumflex, so I gladly accepted that position. And there's some background noise. I'm not able to understand that. Yeah. Anyway, so we got a wire finally, a very graty feeling. I did think that my wire is going to enter the lesion from the bottom. However, it did from the top. And there was a gratiness to this whole sensation, which is terrible. Anyway, got it through. My next was to get an IVUS catheter in, and my IVUS catheter kind of came in, almost struggled. So I thought that taking an IVUS catheter in there through this whole osteal lesion would be terrible because I would have to push it really hard, and that would make him terribly ischemic. So what we did was we just went in with the excimer laser 0.9 fiber. And that took us a while to kind of go past it. You can see that it's struggling, but with 80 and 80 fluency at 60, it did not budge, but at a higher fluency, it went across. And once it did, I think I felt at ease. We did a few runs of that. And once we'd done a few runs of that, we had a very easy pass of the IVUS catheter. And I'll take a pause at some stage and show you these two IVUS runs. So we did an IVUS run from the LAD. back, and we did an IVUS run from the circumflex back, particularly with a view to look at the circumflex ostium, that is going to be very instrumental in what I'm going to do next. We then did we used a 3O balloon, and we quickly realized that at 12 atmospheres, there's a huge indentation. So for me, let's look at the IVUS. We did an IVUS run, and I'm going to go back to that presentation. This is the IVUS run from the LAD to the left main. And if I'm going to run through it, you can see that there is a normal artery there. And as you come along, there is this block. You can see the branch actually facilitates a very larger diameter. The artery has grown. And then you can see the plaque kind of coming in. There's eccentric calcium. You can see heavily eccentric calcium over there. This is a very dangerous part of the artery because these calcified areas, which are eccentric with the normal size of the artery, this is exactly where we need to undersize our stents to a large extent. I'm going to get you quickly down to the proximal part. You can see there's these folds of calcium there around 180 degrees at this present time, sheets of calcium, very eccentric. Then coming down at the ostium, which is very interesting, you can see this little cup of calcium down there, and then fragments of calcium, plates of calcium at opposite ends of this artery. And as we approach the ostium, you can see a huge calcified ring around there, which has a diameter of around close to 2.6 millimeters. And then as we come into the ostium of the LAD, you can see concentrate on these two plates. Sorry, again, I skipped to the other slide. And this is the important bit over here that I want you to see. You can see that there are two bits of calcium. One is protruding from this end and one is from the other. You can see one calcified plate here, one coming in from the other end. And they both come closely and hug that imaging catheter closely. This is exactly where our laser had made an impact. And you can see there's a protrusion of calcium from one end, which is this big dark shadow right here. And there's another protrusion of calcium right over here. And this calcified lesion extends into and that's your circumflex wire right up there. And the circumflex mouth looks okay. But as you come into the distal left main, again, you can see a very heavily calcified distal left main down there with almost like a 180 degree calcium and deep layers of calcium with fragments all across. So we come back a little bit and we realize that the left main proximally is quite good. The landing zone is great. And if you see, we're looking at least a 1, 2, 3, 4, almost a 5 millimeter landing zone, somewhere between 4.5 to 5 millimeter landing zone. While I'm here, we'll look at the circumflex pullback as well. This is from the circumflex artery. As you came in, you can see there's an eccentric calcium. And let's come all the way to the ostium because that is the most relevant bit of information that we can have. And this is the ostium. You can see that the LAD is at the far end. You can see the protruding calcium is almost honing on to that little area of wire. You can see how the calcium just hones onto it from all ends. And as you see the ostium, this is the ostium of the circumflex artery right here. You can see the carina, the figure of 8. The figure of 8 actually identifies the ostium of the circumflex. And when we go right in over here, you will see that that is the proximal circumflex, which means that it has a 1, 2, and 3, almost a 7.2 millimeter area with a very sliver of a plaque right down. So this is a very forgiving ostium, really. But as you come close to the carina, then there's a very discrete area where the circumflex narrows at the ostium, and that is right here. So this is right at the ostium, the non-opposing, the non-carinal wall of the circumflex really comes in. And so if at all we do some damage, this is the only damage that we can actually do at the mouth of the ostium. So after we stent the LED, it's very important to look at this ostium again by ultrasonography for me. Going back to where we go onto the cine pictures, here we are. So we identified this, and this is an IVL 4 balloon because based on the size, we needed to have a complete expansion. And you can see that in a couple of pulses, we could have complete expansion of that area. And we have to be at pause over here a little bit, because when we're doing IVL shocks in a case as critical as this, and we have total occlusion of flow, it is important sometimes to be very watchful about the pressures. And if the pressures are dropping, it's okay to give a few pulses and then stop, and then give pulses of 5 rather than 10, but try not to have a hemodynamic collapse. Also try to keep a little bit of time interval between the 2 trains of pulses. So we keep at least a couple of minutes for the artery to breathe, especially in such eloquent areas. We push that IVL balloon down and we see that we crack more calcium over there. We've done most of the job. So we come back and do a few more in the left main. And after that, this is our picture. We've got a 3O balloon there down based on the based on the IVUS, and we dilate that mid segment of the LED. So we know that we have a long segment of stent in the LED to position, which we do now. Here is a long segment of stent. We go ahead and dilate that entire area. We've got, we do a port with a 4.5 because that's what we already identified on that IVUS. And once this is the 4.5 millimeters balloon going up to very high pressure, making sure that we've expanded that distal area of the left main as well to that area. Typically for port, you don't need to go on a very high pressure, but when you have a distal left main plaque, which is calcified, you got to make sure that it is well expanded, because the distal confluence of the left main, if it is unexpanded, which can be, is a site for restenosis otherwise. For us, this was a great angiographic result from the LAD, but now the ostium of the circumflex is very important and crucial for us to see. So we go back to the LAD, making sure that we've optimized it. And we go ahead and do more dilatations based on the IVUS measurements. We go to larger balloons and just go up to higher pressures, getting the MSAs right. So we use a 4O balloon down here because we did see a little bit of an expansion. And we come back and do the port again. And once we've done that, now our job is to go and look at the circumflex ostium. So we recross this circumflex ostium and do a run of the IVUS here. This is important because at this point, I want to kind of re-exit from here and go back to my slides. Sorry about this jugglery that I'm doing, but trying to just so we left you there last time, and this is the post-stent LED IVUS. You can see that we have, I'm running you quickly, we have areas where I think we could do a little more work, but often enough in these eccentric areas, as James mentioned, as Ashok demonstrated so well, it is better to accept a slightly suboptimal result than to chase it, and especially when there's eccentric calcium on one end and a normal artery on the other. That's the only area that I accept a slightly lower MSA. We come back, and as we come back into the ostium, we can see the ring of cat. This is the area where, in spite of high pressure dilatation, you can see that I've only got a less than 3 millimeter diameter. We need to do more work here. And that's how I decided on the further dilatations that I showed you. The confluence, the distal left main seems underdilated. So that's why we made sure that we expressed a very high pressure dilatation at the distal end of the left main stent. And then, of course, opposing the proximal stent was important. There's a little bit of malposition at the left main confluence, which we also worked on. The next slide is important. And post-LED stent, looking at the circ ostium was crucial for me. And I'm going to come back very quickly to that ostium. You can see the circ coming there. And what I what I saw was when I come in close to the ostium, which is at the crossing, which is you're just approaching there, you can see that there's a little one area where you actually compromise the lumen right at that one spot, which is only discretely associated at the ostium of the circumflex. For me, this is one indication in all my left main PCIs to do a balloon dilatation of that ostium. And currently, I've been using a drug-eluting balloon in that proximal segment of the circumflex, avoiding a stent because I know there's not much atheroma. This is a reason because we've shifted a little bit of plaque, we've shifted a little bit of carina. We've got that compromise of that, even the circumflex stent gets a little pushed over, the proc gets pushed over. So for me, this is a dilatation required over there. So going back to the angio, this is the angio here. We decided to dilate it with a 3.0 balloon, a 3.5 balloon, which was extremely tight, opened up, and then we put in we did a kiss and then followed it with a last, this is a drug-eluting balloon in the circ ostium. Did an IVUS to make sure that it was perfect. We had not screwed up the left main. The left main MSAs, the LED MSAs were all in the acceptable range. A final picture at 60 ml of contrast. This is our final picture, and we closed this case. Left ventricular diastolic pressure was 12 at the end. We used 60 ml of contrast. His creatinine today is 1.1 from a 1.7 on admission, and he is ready to be discharged tomorrow morning. Thank you for this patient listening, and I'll be happy to take any questions.
You have to unmute, Dr. Hazara.
Yeah, first comment from Dr. Sridhar, then Dr. Seth, then Dr. Sunil and Daman.
Actually, it's a nice illustration, particularly using drug-eluting balloon, side branch. So optimization by using the drug-eluting. This is one of the, I think, a very useful technique because side branch, you can avoid one more metal stud where the mace rate is going to be increased. The recently published DEB plasty consensus document has shown very clearly, and not only small vessel disease, ISRs and side branch lesions also, but as he mentioned very clearly, the result should be optimal. If suboptimal, then you have to implant the stent. They have also mentioned very clearly, do the imaging after DEB. Have you achieved adequate luminal area? If there is no dissection, if there is no underaction, if there is no significant, the MLS size is not achieved. In such cases, if you are doubtful, you can do the FFR also. If the FFR is negative, don't do anything. And if the imaging and FFR results suggest to suboptimal, implant with the stent. That is one of the finest method. Thank you very much. Excellent presentation.
Yeah, Dr. Sunil.
Dr. Sunil here. Excellent case, Dr. Punamaya. I had a similar case recently, like five months back. This lady is a very elderly lady with RCA CTO, and she had a distal left main bifurcation lesion. And then, as you correctly pointed out, she refused surgery, so we went with an IVL. When I occluded the distal left main to the LAD, the first cycle I gave 10 pulses, her blood pressure dropped to almost 30, and then she was kind of peri-arrest stage. Then we had to wait for almost 2-3 minutes for the pressures come up, and subsequently I did 5 pulses each every time. And then I did left main bifurcation stenting using DK crush technique. She tolerated the procedure. This was in spite of having a balloon pump. So, but there was some comment saying that if we give 5 pulses instead of the complete 10 pulses, the cooling effect will not be there. So we might not have an adequate effect. What is your comment on this? I could not, apart from the first cycle, I could not deliver more than 5 pulses in that lady, and I had to give 5 pulses, every time, and then I could get good, good result with the adequate expansion, cracking of the calcium. So, what is your comment on that 5 pulses?
So I think that's one of the important issue is that we've had to use 5 pulses or shorter pulses only in one particular case, which was not this one. We used all the 10 pulses for this. This is an important lesson to learn in the left main, and I think this becomes more of an issue because if you have left ventricular and diastolic pressures, which are very, very high, and you start doing left main occlusions, they suddenly go up. And when the circ, you occlude that circ, you have mitral regurgitation, your pulmonary artery pressures going up, your LV and diastolic pressures, the patients get hypoxic. And that's where the problem is. And so early identification of an impeller assisted, and therefore when you place an impeller, these pulses become more deliverable and you can complete your procedure a little more uneventfully. So I think understanding hemodynamics is the key in the left main. I think that's one. Two, if you, like in my case, I had to work on the left main, and I also had to work on the LAD a little bit. So you do one pulse train in the left main, get a little bit of flow, take your ideal balloon downstream a little bit, work on that so that your circumflex get some flow in the interim. You give it a break. You don't do repeated trains of pulsation right at the left main all the time, is what I have learned in my practice. So I kind of go back and forth in that artery a little bit, go downstream, give a couple, then come back and do a left main, and then go back into the LAD. Maybe that helps, because that gives you a bigger breather space for the left main, because the left main in a left dominant circulation is all that the man has, and you're really compromising it for a minute or so.
Doctor said your 2 commandments.
James or Ashok, would you do anything different for these circumstances?
No, I think you're absolutely right. I don't think it makes a difference around whether it's 5, 7, or 10. I think it's the total number of pulses that you end up delivering for a particular lesion. But it's also important to understand that sometimes you have to position balloons according to where you want to treat the lesions. For example, if it's ostia and it's a large left main, deal with the ostia. Make sure that your circumflex is flowing, which you can often do. So deal with the ostia rather than bring your whole balloon and try and occlude it. The effort is that unless you have to treat the left main, and remember, most of our balloons are undersized to the left main, we are either treating ostias of LAD or ostias of circumflex, which I agree that in majority of this, in a lot of times, you will occlude the left main, but there are times that if you position it accurately enough, you'll still have flow in one of those vessels while treating the ostias. And I think you have to endeavor to do that, not just believe that everything has to be sitting in the left main and that's the only way to do things. He's demonstrated it well. I think Kirti has demonstrated it well, that you just give artery time to breathe and breathe more when you do left mains. You actually have to let them recover. You must also keep in mind one other thing which hasn't been mentioned. The more times you occlude a left main, the worse the consequences get, because you're stunning the myocardium each time. So the breathing time has to be much longer. And you may realize that after 3rd or 4th time that you've occluded the vessel, the things are getting bad for the patient because his PA pressures are going up. They haven't come down. You actually are stunning the myocardium more and more. You do that for 8 cycles and 80 pulses, you're actually going to be in deep trouble. Also, don't believe you got to deliver your 80 pulses. What you got to do is, if in 15 pulses, in 20 pulses, you have an adequate expansion, do the remaining job with a non-compliant balloon. What you've done is got most out of the least. That's what I would say.
James, out of 10 Moses commandment, what will be your first commandment to the case of this case?
Yeah, I mean, I thought it was a great case. And what I liked about it the most was the systematic use of imaging to assess the risk, to understand how to treat, to assess the response. It was really beautifully done. I think, getting back to the comment about IVL and the risk, incremental risk of IVL in the left main, I don't think the incremental risk is very high. I do think the function of these patients who deteriorate with left main inflation, it's a function of upstream, how brittle they are. And I think we actually have the data to support understanding those patients. And I think LVEDP is absolutely critical. I think that's absolutely critical. But there certainly are patients with older, stiffer ventricles who just don't bounce back in the same way that the younger patients will. So I think certainly age does seem to be a real predictor of how well patients bounce. And I think Ashok's comment about that ischemic spiral is particularly relevant for these older patients with stiff ventricles that, in the absence of LV support. But it was a beautifully managed case and fantastic results. So well done for that.
Yes, I must comment on the case as well. Kirti, great. Very, tremendous demonstration of imaging and how imaging actually made you decide. I mean, you're always do this so well. This is so well done.
Thank you. Thank you, Kirti. It's my pleasure to invite Dr. Seth for take over the sessions. Let me present my case.
Dr. Hazra, just 1 second. So since Dr. Rajneesh Kapoor, the moderator of the event, is offline because of some emergency, I would like to take this opportunity to invite our next presenter, Dr. P.K. Hazra from MRI Dhakuria Hospital, Kolkata. Dr. Hazra is the Director of Interventional Cardiology Unit at MRI Hospital with more than 25 years of experience in his medical profession, specialized in pacemaker surgery, coronary angioplasty and coronary angiography. He has won several awards and achievements to his credit, and one of his achievement is an installation of an artificial heart in a man. And recently, that is yesterday, he has completed 52 cases of IVL in India in his cath lab at MRI Dhakuria Hospital. So welcome, Dr. Hazra. Please start your presentation, sir.
Thank you. So here is my man, elderly, 80 years, non-diabetic, high troponer, ACS, mildly reduced ejection fraction to the range of 40 to 45. RBB on the background, normal GFR, normal peripheral vessels. And Covishield has been taken 45 days ago, and he developed thrombotic thrombocytopenic purpura, a Reynolds-like phenomenon in all 4 lanes. So it's basically suffering from VIT, vaccine-induced thrombotic thrombocytopenic purpura, which has got a tremendous relevance to my case. And he's got a left main bifurcations. I planned elective PCI. He's got distal calcified 50% lesion to the left main. LED long 80% lesions, not that severely calcified on angiography, circumflex osteum 90%. And ABC, on ABC classification is A, B, and C, that means more than 3.5. Left main, B is basically LED more than 3.5, and C is more than 3.5 circumflex, Medina 111. Low syntaxer, calcification is also there. On the IVUS, height branch is less than 10 millimeter, and 90-degree angle of bifurcations. And here are some still images. You must have noticed that several branches arising. These are critical circumflex lesions. Here is a trifurcus lesion of the mid segment of the LAD, and is a tapering lesion of the left main. There is some calcium on the roof as well on the floor. And I planned this case on IV cangrelor because I thought that maybe thrombotic thrombocytic purpura, if he develops severe hemorrhage, this is the only reversible agent. It can be reversed within 5 minutes. The increased incidence of bleeding can be counteracted by a bivalodin. By my mistake, which I did, the heparin is actually contraindicated with a VIT, but later on he was put on bivalodin. On noradrenaline support 24 hours before, a femoral 2.5 impella, radial 7 sheath, dedicated shoe stent, and DK cross was my plan because I was guided. Vivo was in circumflex and Giants was on left main LAD. He required a short-term support because of limb Reynolds-like phenomena, and as I said, VIT, that is vaccine-induced thrombotic purpura, 90,000 platelets, intravascular hemolysis was demonstrated because of TTP with presenting RBC and high LDH. Circumflex was a side branch, LAD main branch, double kissing, double cross. IVL was used 3.5, 7 pulse in LAD. So investment was done mainly on the LAD because of the long tectonic plate, and osteo is very short lesion. So 3 investment was done, 3 pulses were done in the circumflex, report, a proglide closure, immunoglobulin was injected, plasmapheresis later on, and it was overall with ticagrelor. So I was quite certain things were not known to me: limb outcome, bleeding, and stent thrombosis, complete heart block. He developed immediately after putting the wire insertions in the LV to 0.21 wear of the impella, which is totally unpredictable, and it was unexpected. It persisted for 72 hours, and even today he is on double chamber pacemaker on a background of RBB. The MSA of the circumflex ostia was not that great. I was expecting a flow like this in the LAD, and there is some constriction in the circumflex ostia. I was expecting because of severe calcification of the ostia, and whatever you do with the DK cast, once you treat the circumflex, that is the minimum thing you can achieve. So here we started with, as usual, for the beginners, it's not for the experts, that we always start with the short, this micropuncture sheet. We look at the femorals to reduce the vascular complications of any large bore device with a 2.5 or 5 impella CP. or any other TAVR, we start with this micropuncture injections. Then we use proglides. So 10 o'clock and 2 o'clock proglide, and we are careful in monitoring the rhythm. Suddenly, after passing the pigtail, he developed complete heart block, which was unexpected. Then he was put on a temporary pacemaker, and this is temporary pacemaker. He continued to have complete heart block. So this was dedicated to one which should not be replaced with any other manufacturer. And once you do that, then you pass your guiding catheter. You check the hemodynamics. He was requiring full support. The noradrenaline was reduced once we started impeller. And so simultaneously, noradrenaline was reduced because of the shock. And he was gradually improving after we opened the circumflex and the LED with a balloon. So this is the impeller 2.5. This was my first impeller. And maybe many people's dream to have this kind of device, MCS device, in their cath lab territory, because it is costly, but it is life-saving. And we have learned from our master that it definitely gives value to the life. And I mean, it saves a lot of people from devastating deaths. The connection was checked, and this dextrose and these connections. Now, once we have this, then we are ready with the angioplasty. So this is the IVUS. I mean, this is the IVUS. This is the angiogram. This is the angiogram. So there is some slow flow in the LED territory. There was obvious lesions in the circumflex. So 2 wires and the LED, and 1 in the circumflex. That is for the beginner, not for the expert again. Usual wire, usual imaging. So IVUS did show some patchy calcifications, and we are prepared with IVL. We thought we'll give IVL because if you give IVL, the chance of dissection, slow flow, no flow, and distal embolism much less in a setting of cardiogenic shock. So if you produce any distal embolism in this elderly man with high troponin and a lot of monks there in the LED, you may occlude one of the side branch. If you occlude diagonal, he may die. I mean, if any occlusion of any major vessel can cause devastating outcome. So IVL in that way much more forgiving for distal embolization and slow flow, no flow. That has been observed in my practice. So IVL 3.5. So all 80 pulses were invested, and then circumflex stent first. The giants. This is a Vivo 3.5, exactly placed over a guard balloon. Then the balloon was inflated, first crush, recrossing. The usual steps were taken, and this is the long stent. I did not cover the ostium, so stent were placed, post-dilated, then again recrossed. Then we checked the apposition MSA. We post-dilated with a larger size balloon, non-compliant balloon, and the report was done with the compliant balloon of 5 millimeter balloon in the left main. Sorry. So this is IVUS. This I'm going quickly. So this is a chroma. This is available only in the Philips. So there was adequate. This is one of the tool to know or understand for the beginners. The flow can tell you that the stent has approached nicely, and gradually we could reduce the flow rate or the impeller support. And so this is ultimately we saw on the table a good outcome on the left vein. And we actually check the peripheral pulses. Sometimes after proglide, you can occlude the femoral. So there was some residual elusive constriction at the circumflex ostia. It was unexpected. There was some slow flow, and then we removed the impeller because we thought keeping this large bore device on the top of vasospastic conditions, thrombotic purpura, hemolytic conditions will add to the problem, as hemodynamically his pressure came out. He came back to the normal. He came back to a normal systolic and diastolic pressure. Even output was good. This is 2 closer done, and we remove the impeller on the table. Hemodynamic is stable. closer, then check the pulses. It was okay, but on the hands, both the hands were having severe vasospasm and cyanosis because of the Raynaud's. And I think we'll stop here. So this is my case to conclude then. So basically, we took the help of MCS in elderly man with ACS, and we took help of the beautiful stent, the biopolymer. This is biodegradable polymers, where the antiplatelet may not be an issue for long term. Then we take the advantage of imaging, IVL to break the calcium, to stop distal embolizations, and to prepare the bed. Thank you for your kind attention, sir.
Sir, Dr. Sokset has left for some emergency. I would request Dr. Kirti Punamiya sir, Dr. Sridhar sir, and Dr. Sunil sir to have questions and basically to take this discussion forward in the evening, sir. Over to all three of you, sir. Yeah, Dr. Kirti sir.
Dr. Hazra, that was an awesome case. I mean, it's always a tremendous delight to you put in your first MCS impeller device and kind of do complex PCI. And it is interesting. Did you, at any point of your inflations, and did you have any LV aortic uncoupling of pressures?
Yeah.
You did.
Yeah.
That is a great sign that, you know, you made the right choice in the impeller, because otherwise these people have hypertension, which is quite remarkable. Dr. Kasturi, any comments on Dr.
Yeah, absolutely. A very nice case, classic chip case where MCS support the very critical lesions, and choosing the IVL, particularly as the DISRUPT study has shown very clearly, as I mentioned, highlighted that slow flow, no flow dissections are very low in such high cases. A roto sometimes may associated, like it may, patient may fall into a trap of our vicious circle. So that is also one of the determinants factor that choosing the IVL, and everything very nicely, elegantly demonstrated. Very good, complex case. Congratulations, sir.
Awesome. What about your imaging? You know, you use the volcano imaging. Do you sometimes notice that in these patients, there's a slightly higher profile imaging tool than most of the others? Do you feel you see jumps and skips when you're pulling back? It jumps, and sometimes important MSAs can be missed. And could you have used a Refinity from the
Philips? Yeah, I see you have 20 megahertz, as you know that. Yeah, Philips. I have the Philips, so you cannot have both of Boston and Philips in one lab. So whatever you have to use the best of it. The Philips advantage, you know, the bulkier device with 20 megahertz by 0.1 French, unlike Boston. But the beauty of this IFUS is like left main. If you have too large left main, too big, then you have lower heart gives a better imaging field than 60 hertz. If your 60 hertz is good for medium size and smaller size of vessel, MSA is an issue here. But MSA, I was quite sure, whatever maybe they may say, I'm going to dilate this left main with 5 millimeter available balloon, whatever is the maximum balloon. That is the maximum size of balloon, coronary balloon available in our lab. I do not know whether we have 5.5, but as per my knowledge goes, 5.5 is used at 18 atmosphere. So it doesn't matter. I mean, if you can achieve 15, 16 millimeter square of wet paint, with some malapation there, or at the 10% from the 100%, I mean, at 90% or 85% of expectation, I don't mind that. But definitely you are quite right that 20 megahertz, the clarity is not that good. But the advantage, you can plug and play, like you can go here and there, 5 minutes. So in many arteries, 10 times, 20 times, you have BH, you have chroma. So you can have this kind of pleasure of using this. Otherwise, HDI was the best.
Dr. Sunil Kumar, any comments that you'd like to make on this case, on this wonderful case?
It's an excellent case with a nice demonstration of the impeller. I mean, you know, not particularly this case. I just want to have a comment from all the panelists here. Like, you know, in the DISRUPT 3 study, actually the unprotected left mains were not involved. Whatever the study was done in the protected left main. How far, you know, one thing is we are justified to use IVL now in an unprotected left main. That is one thing. The second thing is that in the DISRUPT study, what they have done it, At the end of the 10 pulses, I think they have increased the pressures to 6 atmosphere, from 4 to 6 atmosphere. I mean, how many of the panelists here they regularly, use in their routine practice? These are the, two doubts which I have in my, my mind. I think Dr. Punamaya, Dr. Sri, Dr. Hazra and Dr. Sridhar can.
Dr.
UK-Italy study has demonstrated that in left vein it can be used. The 6th atmosphere thing, sometimes in heavy calcium you can perforate the costly balloon at 6th atmosphere and the whole thing is gone. So use your 6th atmosphere, and Kirti, I think I heard him last meeting. They never try to use this balloon as a high pressure balloon or dilatation balloon. So 6th atmosphere, I think it will be the last cycle where you don't mind if it ruptures. Over to you, Dr. Kirti.
So I think the reason why the 6 atmospheres is advocated, I mean, is being done by a lot of operators is because, when you are doing these pulses, that those sensors transmitters get very hot, and they're putting in that little extra thing, cools it down, or is it a part of the cooling process or something? Because you kind of want to just wait till you get the green light and your sensor temperature is back, because if you kind of deflate prematurely, you're going to weaken the wall of the artery because of the hot transmitter touching it, and therefore you kind of compromise your balloon. I think that's the reason. I don't do it in my practice. I just don't go to 4. I don't go to anywhere above 4 because I think that there is no data to support that does any good. You just have to be patient after you finish your IVL for the green lights to come back so that your transmitter temperatures have cooled down, and then you deflate. I think in the left main context, the problem is when you start doing this in the left main context and those 5 extra seconds that it takes for the temperature to cool down, that's when your blood pressure starts going up. So whenever I am doing a left main PCI, which is in a left dominant circulation, I have a very low threshold to put in an impeller if my LVDPs are more than 20. But if my LVDPs are less than 15, then one of the things to do is hydrate these patients very well, even before you do those shock waves. And 2, keep a central access and run a noradrenaline infusion and maintain vasoconstricted state to maintain a blood pressure or mean arterial blood pressure of almost 90 to 95 millimeters of mercury. And when I do that, I've frequently observed that I don't have a problem. It's when I don't have noradrenaline on board and I see very rapid deteriorations of blood pressure. So just keeping NORAD on board makes a big difference. Sridhar, you have any question? You think you have any comments to make on this particular question?
Usually I go for 6 atmosphere also, but if not very critical lesion, I will even left main bifurcation. I use kissing also. One balloon, IVL into the LM to LAD, whichever is tighter, and another balloon, NC balloon into the side branch. I give IVL pulses. Many times those IVS pulses will radiate to even transmit to the side branch balloon also. So simultaneously you can modify the side branch RCM. Usually I practice, but if it's a really critical lesion, I'm hesitant because it can cause this, because you are uploading for 10 pulses. Definitely that can be. So that time rapid deflation. So I think, but he illustrated very nice case. I think I can move on to my case. I think if you allow me to share the screen, I'm ready to go ahead.
Perfect. Awesome.
Yeah, please wait, Siddharth. It gives me a pleasure to introduce Dr. Sridhar Kasturi. He's a senior intervention cardiologist in Sunshine Heart Institute, visiting professor, and head of the Department of Cardiology of Chalmeda Anandarao Institute of Medical Sciences. Awarded as the best cardiologist for outstanding contribution in the field of cardiology from Council of Industrial and Trade Development through Honorable Governor Mr. Sujit Singh Barniwala of Andhra Pradesh, fellowship from Indian College of Cardiology and American College of Cardiology. He is a great operator. His stature is larger than life. He's a good friend of mine and a teacher, and extremely useful. I would say as a professional colleague to understand the complex PCI imaging. And over to you, sir. Dr. Sridhar.
Thank you very much, sir. I'm very much honored to listen to those words from you. And it's a very great privilege and pleasure to associate with all of you this evening. You just allow me to share the screen. Yeah. Yeah. Are you able to see my?
Yes, sir.
Yeah. This case is a IVAS-guided DK cross-stenting of severely calcified left main bifurcation, plaque modification using IVL. Today, we did one very high-risk complex PCF left main bifurcation. The gentleman, 65-year-old male patient, has been suffering from recent onset of angina. Treadmill was done. Treadmill was positive, significantly positive. Is a known hypertensive, known diabetic, and investigated outside. Angiogram was done in some other tertiary care hospital. After angiogram, became the calcified distal left main bifurcation involving the LAD and LCX osteums. You can see the LAD is very, very tight. Proximally, distal left main is diseased. And even you can see the LCX origin also very, very tightly stenosed. If you see here, it's like a Medina 111, a distal left main and calcium. You can see the calcium extending from distal left main into the LAD and also extending to the left circumflex. So if you see the angle of the left circumflex, it's more than 120 degree. So it's a very difficult angle to cross with the rota. You can see the right coronary, these are significantly diseased. Patient was posted for surgery. Then he was totally reluctant, even family member also. Then he shifted from some other hospital. If you see the distal left main is very, very tightly. There is also another early OM, almost like a trifurcation lesion, distal left main, LAD, calcium extending from distal left main to the LAD, left circumflex involving. So Medina 111 and even early OM is arising from almost trifurcation case. This is a case of trifurcation. And you see there is a big OM, even if you see the very clearly. So because the right coronary is significantly diseased, it's a calcified Medina 111, uninfarcted vessel, more than 1 degree angle. Something goes wrong, definitely he requires pacemaker support. So that's the reason what we thought we'll put a balloon tipped pacemaker to avoid injury. Nowadays, always we are keeping the balloon tipped pacemaker to avoid any perforations. So before proceeding for any CABG, certain things we have to consider. Assess the SINTA score, assess the STS score. I always insist for any patient when we are doing the left main, compulsory to opt for imaging. Because imaging, if you see all the studies, like even recently published XPL study or ultimate study, definitely all these like even if you see main compare or Excel sub-study, all these studies have shown very clearly the MACE rate is drastically reduced with the image guidance. Almost there is a decrease in the tendency of thrombosis, stent thrombosis by 50 to 60%. And another one, whether MCS support is required or not. In this case, we avoided the MCS support because hemodynamical is stable. What we thought, but always we keep access, the left femoral access, and we always keep the ECMO and IABP ready. If there is if something goes wrong, always we are ready to support it with the hemodynamic support. So most of the time, I always hesitate, and unless if your elbow dysfunction is there. Why? Because these are large bore sheaths. Peripheral complications are also very high. That's the reason if it's really mandatory and if it is required only, then I will go ahead with the, you see here, angle is really more than 120 degrees. If I do the rota, many times the chance of crossing difficult, rota entrapment may be very high. If at all, if I use rota, definitely LAD I will be very successful. But LCX, we have to be very slow, and ultimately we may end up with a half rota. So at least proximal half, do the half rota and subsequently take the balloon and modify. So here, because the another one is slow flow, no flow section is also very high compared to that one. So right coronary backup is not there. That's the reason I opted for IVL. So I wanted to see whether really this patient requires, when we are doing whether balloon crossable or uncrossable, that decides my strategy. So whenever you choose any strategy, whether you are going with a single stent strategy or two well stent strategy is very, very important. And accurate vessel sizing is important by imaging. Block modification is also very, very important in this case. So you have to use block modification, otherwise under expansion is very high, and crossing the stent is also very difficult. So you should be familiar with the two stent technique. Various techniques you should be familiar, but I opted for DK cross stenting in this patient because the best outcome data. So always assess the STS score and assess the Euro score, and always aim for the complete revascularization. So these are the important factors whenever you do the left main bifurcation PCA. So any patient, whenever they comes, look for comorbidities, assess the scores, how is the LV function, EDP you check whether really requires hemodynamic support or not. So based upon that, before that proper stratification is very, very important. So you should also know class 1 indications, PCA versus CABG. And always when you are counseling the patient, definitely you must highlight all the important, even syntax data, 10-year data has shown, where even pre-combat data has shown very clearly, there is no change in the mortality in left main disease, even at the end of the 10-year also, almost similar trends. If you see this comes under complex bifurcation. So more than 90% block and more than 10 mm blend. And if the MACE rate is significantly falls, 18% versus 7% when you are choosing the DK crush. That's the reason here in this case, it's a complex bifurcation. Definitely we have to go ahead with the DK crush because of the supportive evidence of the long-term better results. So if it is always, if you don't have having an image, assess the calcium properly on angiography. Is it moderate or severe? If it is severe, definitely block modification is must, and also pass the balloon, whether are you feeling any grating sensation, balloon crossable, uncrossable. So even if we are unable to cross the lesion, at least after block modification, do the imaging, and after that, any calcium fractures are there, any ablation adequate or not, very, very important. So these are the various data, very supportive of like a image guided versus angio guided. So definitely outcome is much more favorable with the image guided, particularly this was well proven in ADAPT-DS study where the complexity of the disease increases. Definitely outcome is much better. Compared to single two vessel disease will have better outcome when you are using IVAS versus angio. So this algorithm one should follow, that is it a balloon crossable or uncrossable, or you can see the balloon behavior, any dog bone effect is there. After that, if it is moderate or mild, you can do the NC balloon. If it is very severe calcification, balloon crossable, you can use the IVL or rota or laser, or if it uncrossable, you can use the laser as well as the rota. Subsequently, you can go ahead with it. So these are steps you should understand before going for any procedure. So if it is uncrossable lesion, remove the side branch wire. You can go with atherectomy, rotablation, or if it is crossable, you can go ahead with a lithotripsy, still undilatable, remove the side branch wire. Again, you can do the atherectomy. But lithotripsy, after that, even open NC also works very well. It can produce 35 to 40 atmospheres. That also you can do. If, even after rota also, even without lithotripsy, you can also use the IVL open NC balloon to get the good adequate expansion. So mainly this angle is really unfavorable. That's the reason I was reluctant to do the rota. So that's the reason I have chosen mainly for this option of going for IVL mainly. because the very low incidence of stent thrombo, very low incidence of the dissection, slow flow, no flow. Here, if you see, when we are giving the, initially we put the 2 wires, one into the LAD, one into the LCX, and always 2 wires are mandatory. And if rota is there, suppose if I remove the one rota, if I'm doing LM to LAD, because the angle is unfavorable, it can close, and it's very difficult to cross in at that time with the calcium is closing this one. If the block is extending to this one, it will become a definitely emergency situation. Another one, if you are going ahead with the LM to LCX, again, crossing it difficult. If the dissection, it closes the LAD also, that also a big problem. That's the reason, based upon the angle. So I thought it's preferable to go ahead with the this one. So then initially we have put the 2 wires, one into the LAD, one into the LCX, and initially we dilated. So we dilated with 1.5 and 2 mm balloon. So because it's very angulated, when we are pushing the wire, always it was going into the OM branch. So then nowadays we are using more of supercross, which is very useful in angulated lesions. I also use crusade more frequently. One wire put into the OM and take another wire, you just redirect. So it decreases the procedure time. Crossing time will be very short. Initially you try with a simple wire. If you are facing difficulty, take the angulated catheter and redirect, and you can push the wire. Because calcium and multiple bends are there, then I use the supercross, then cross the lesion. So I wanted to see the behavior of the block. Then initially I tried with 1.5 mm and 2 mm balloon. These are the dilatation. You see, we were facing a lot of difficulty in crossing. So then ultimately with great difficulty, we could cross and we could dilate the LCX lesion. Then subsequently, I thought of both LAD and LCX was dilated. My intention was to go ahead with a IVL 3 mm balloon. So when we tried with the IVL 3 mm balloon, you see, it was not going. So even with the guideline support also, we were unable to cross the LCX angle. So when it is not crossing, the first IVL balloon got ruptured. So when we went up to 4 atmospheres, immediately balloon ruptured. Then I took the another 3 mm balloon. Then I changed my strategy. At least let us open the left main to LAD. And once you give pulses, then go ahead with the LCX block modification. So you see here, you can, as just now we have discussed, now you see the pressure tracing here. Whenever we are going to 4 atmosphere, pressure is steeply falling. After giving 10 pulses, then you can see the shock topics, and you can also, the pressure is falling up to 20 atmosphere. Then immediately we went up to 6 and then deflated. So when we deflated, the pressure picked up. For every cycle, we were inflating briskly and deflating. Up to once we completed 10 pulses, he was tolerating well. But once it's completed, then immediately pressure dropping, then immediately increases to 6 and deflated. And then we allowed it to breathe. So you have to give us some time to perfuse, then subsequently repeat the cycle. So this is, as you all aware, whether you give 5 pulses or 10 pulses, it is going to generate 50 atmospheres. The microcavitation, expanding and collapsing bubbles, that can create the 50 atmospheres. Each shock wave can produce a 50 atmospheres, even if you give 5 pulses also, very effective. This diagram definitely illustrates, even in eccentric block also, it is very useful, calcific nodular, eccentric. But the only thing is the number of pulses you have to give more compared to concentric calcification. If you see it illustrates very nicely. If concentric because all. So then we opted for DK crush. These are steps like a side branch stenting, crush the stent, and first kissing, then main vessel stenting, then again recross, and final kissing, then followed by part. These are standard steps. So then we have placed the guideliner to place the stent. You see, still we are, this stent we are trying to place into the, even after IVL, even after multiple balloon dilatation, it was requiring the guideliner. So there is a significant calcium and involving the significant LAD and LCX ostia. So that's the reason we deeply placed the guideliner. Then this is the LCX stent. So we are keeping the balloon into the LED. Then we have pulled into the, you see, then dilated stent. Then we pull the balloon to, then again, we are recrossing the stent starts with the supercross. You can see the angled supercross, then dilated the opened stent struts. Then this is the first kissing. You can see very clearly first kissing. Then after first kissing, then LCX stent was again further optimized with further inflations of 3 mm NC. Then you can, now we are implanting a 3 mm into 3.5, sorry, 3.5 mm into 28 mm stent, science expedition, extending just before the diagonal to the just ostium of the left main. So this is the main well stent. So DK crush definitely scored over. Whenever you whenever putting the stent in the left main, you should know that expansion capacity of the stent. So if you take 3, maximum you can go up to 4.1. So here the vessel size is more than 4.5. That's the reason we went ahead with 3.5. This is part. Then part was performed using the 4.5 mm NC below. This is the part. So part is must before going ahead with a second kissing, because if you otherwise balloon wire may go obliminally, that may cause a problem. Again, we use super cross, then recross. Then you can see very clearly the second kissing. That is after crossing, then second kissing. So don't extend too much into the left main. And this is a dot. So distal optimization technique using the distal portion of the LED. Again, L6 was further optimized using 3 mm below. Then subsequently, this is the report. Always end with a report, because the kissing balloon can cause asymmetrical expansion. So this is the IVAS run. If you see the IVAS, the distal landing zone, we can see very, very distal to the stent. You can see very nicely. And nicely expanded stent. This is LED study. You can see very clearly. These are the branches, small dissection. It's not very significant. And you can see very clearly the stent. Stent is expanded very nicely. Luminal area is very good. You can see the whole run. This is LED I was expanded very, very nicely, almost like a spherical shape. That is very, very important. You can see the dark shadow. This side is the calcium, but this side there is no calcium. This is the LCX origin. You can see the left main. So this is LCX IVAS. You can see LCX IVAS also, the spherical shaped, the symmetrical expansion of the stent. There is a branch, that's the reason you are able to see mild. This is a left LED origin. You can see again LED. There is a mild malopposition here, but the area achieved is extremely good. And you can see mild malopposition is not very significant. But anyhow, after that, we did the again further optimization of one more part technique. So this is the even stent is expanded very nicely in the left main. See, you can see that this is the calcific portion, but these air quadrants are free of any calcium. This is the ostium of the left main. So always you see the areas. You can see the LED ostium 10 square mm, and you can see the distal landing zone is almost 10 square mm. You can see the absolutely nicely expanded LCX ostium. We got 7.6 square mm, and you can see the proximal LCX 9.3. And if you see the LM, almost you can see the proximal landing zone, that is LM is almost 5 mm, 19.9 square mm. LM shaft 18.6, 4.7 mm diameter. So entire segments, all segments, the polygon is nicely expanded, that 8.765, but we got 18, almost even LED got 10 square mm. So always you should know part balloon where to keep when you are optimizing. So don't push too much into the carina, and at the same time, so don't pull back or don't extend beyond the proximal segment of the stent. You should know these limitations when you are doing the part. This is the final angiograph views. You can see LED is nicely flowing and expanded very nice and nice segments of all LM, LED and LCX. And LED distally disease free. And you can see L6 is flowing. Finally, we have seen all the peripheral pulses. The Even if you see the femoral pulses flowing very well, we use the proglides to close it. So when you are using the bifurcation, always you should know the chart. So first, whether you are opting for progenyal stenting or two-stent technique. Suppose if the side branch is not significantly involved, then you can go with the progenyal stenting. But that is side branch more than, after progenyal stent, if the side branch is more than 75%, narrowing is there, dissection or flow limiting dissection or decreased flow, ischemia is there, that time you can go with the T-tap, or you can go with T-stent or Poulet technique. Suppose side branch is less than 70%, no dissection and normal flow, no ischemia, still angiographically you are doubtful, check the FFR. If the FFR positive, you can consider, as Dr. Punamia mentioned very clearly, you can go with the DEB option. Otherwise, suboptimal, you can go with the destenting. Other option to FKB, you can also think of part side part, or you can do the kissing balloon. If the complex bifurcation, always preferable to go with the two-stent technique. But the two-stent technique, most preferred, even ESC guideline 2018 clearly mentioned, whenever you do the unprotected left main bifurcation two-stent technique, the DK crush, wherever possible, is the most preferred technique. Even in AGC guidelines, they are mentioned very clearly because of the data. It's scored of the Poulet, it's scored of the crush, it's scored of the T-stenting. So even the latest data, DK crush 5 trial, so I've shown very clearly, even compared with the progenyal, if the complex bifurcation is there, definitely it scores over the progenyal stenting. So you can opt for Poulet, systemic T-stenting or DK crush stenting. But finally, all two stentings, its final kissing balloon is mandatory, part is mandatory. Optimization is very, very important for these patients. So whenever you are doing the bifurcation techniques, always preferable to use the image, preferable to use before the procedure and after plaque modification and at the end of the stenting. But here, because of the complex procedure, I thought then we will to shorten the time, because even passing balloons were also, we were facing difficulty. Angiography, very severe critical lesion. Avoided those 2 steps, but always I insist to do the 2 procedures, because assess the severity of the plaque, assess the balloon sizes, and subsequently you can also, once the plaque modification done, once you are giving the IVL, plaque fractures, that calcium fractures are seen or not, because that is one of the predictor of the future MACE rate. If TLR significant, if calcium fractures are seen, TLR rate significantly reduced, ISR rate is going to be reduced significantly. That's the reason before implanting the stent, have you achieved adequate calcium, the plate fractures or not? If plate fractures are not, better to use another modification device. Suppose if you are using IVL, you can use the open NCA, or you can go the cutting balloon, or you can use the rota, or complementary to each other, like a rotatripsy or any other combination. You can work. I think that is the way to move forward. I think, thank you very much for paying attention. And I hope this will be very useful in day-to-day practice. Thank you very much for paying attention.
Thanks, Dr. Kasturi. It was overall good deliberation. Hello?
Thank you very much, sir.
Yeah, so very good deliberation. And I think all steps revisited in a nice manner. I just want to congratulate you for wearing that radiation protective cap.
Thank you very much.
That was really good. And all in all, I think the left main bifurcation, you showed us a good way to be very meticulous with all the steps. So thank you for that. Sorry, I was in and out. There was some procedure which I had to go and do it. So messages were very clear. I feel, wherever we face a lot of heavy calcification, I think the first message is, if I have to just put it into a synopsis, the first big message is that if we find a concentric calcification or a moderate to heavy calcification in coronaries, let's not be shy away of using these newer gadgets. This is really good, and it works wonders if we start planning from the word go. while analyzing the angiogram and deciding that if there is a calcification moderate to heavy, so let's either plan a rotablation or a IVL from the beginning. Yes, the further how to use rotablation discretely or IVL, that's always a bit of dilemma. But I feel if we find that the thickness of calcium is very heavy and angiographically it looks like that it's protruding into the lumen and causing a lot of restriction inside the lumen, then I think it, it goes towards more usage of rotablator. But if it is a concentric 360-degree calcium as a thick layer, not protruding into the lumen, but still restrictive, there's obstruction, then probably IVL is better, although this is still overlapping. There is no hard and fast rule, but this is the broad points on the basis of which we can select where rota or where IVL. And if possible, if we can use IVUS or OCT prior to the usage of these debulking devices, then that's going to guide us in a much better way. So we should not shy away. We should use these debulking devices, calcium breaking devices, because as Dr. Kasturi was mentioning clearly, once we do that, once we change the compliance of the vessel, then expansion of the stent is definitely more efficient, and that under expansion is gone, and that actually transforms it to a better outcome in the long term. There is no doubt about it. So this is one big message, that let's not shy away. Second, we should be very meticulous in using all these devices, know exactly all the steps. We also talked of that imaging prior to the usage of this device is very helpful, since it gives an accurate size of the vessel, which at times, if we are planning an IVL balloon, we should not undersize it. It should be well in touch with the vessel wall, and that is only possible if we have actually measured the vessel caliber with IVUS or OCT. So imaging along with this is very important. And then obviously good execution of all these steps and, completing the procedure and getting a good success of the procedure is, as we all do on day-to-day basis as a astute interventionist. So let's keep doing that. And these are the messages. And I feel this was a very well-planned symposium, Pankudi, and all the Translumina guys. Thank you very much for involving us, and the messages and cases were good.
Dr. Sunil Kumar, sir, if you have any comments on Dr. Kasturi's presentation, sir?
Excellent demonstration of decay crush in the left main bifurcation technique using IVL. I was really impressed with the use of supercross. I think it comes in two angles. I don't know which one he used.
No, actually you will have a 45 degrees angle, 90 degree angle, 20 degree. So you will have a almost you have a 4 angles. So depending upon the bifurcation angle, you can choose the micro catheter. Here I used 90 degree angle catheter.
Yeah. So, another one which we can use is the Venture catheter, where you can change the angle based on the, so one catheter can be used for all those things. It was very nice demonstration. As always, Dr. Sridhar has excellently demonstrated it. Nice case, no more comments.
Just to tell all the participants, we have 756 live viewers right now. So Dr. Sridhar Kasturi, since you are a pioneer in using imaging in your region and you are also coming up with a book on imaging, we have a lot of questions on imaging specifically for you from the audience, sir. So IVUS or OCT, which one is the better modality, imaging modality, whenever you are treating calcified lesions?
No, actually, both tools, you can use any tool, whichever is available, but imaging is definitely mandatory. But the interpretation of the OCT is very easy because the resolution is very high, very easy to interpret. So, but if the ostial lesion is there and the short left main is there, sometimes when you put the guide catheter, you may miss the left main ostium. In such cases, if the renal dysfunction is there, severe LV dysfunction or unstable hemodynamic status, better to prefer go ahead with the IVUS catheter. But otherwise, most of the time, in our 80% of the case, we use the OCT only, even left main also. So even ostial also we are doing, ostial ISR also we are doing with the OCT, but that time you can keep the guideliner, and with the guideliner high flow, you have to maintain more than 6 to 8 ml per second. But IVAS is also very useful tool. You can pull and you can see the ioto-ostial junction very nicely. But whatever it may be, don't hesitate whether IVAS or OCT, but try to use some imaging when you do the left main, because the optimization is very, very important. Sometimes angiography may not show the calcium. Sometimes it may not show the underexpansion. Sometimes it may not show the malopposition. So in such cases, if you are leaving the left main is a very crucial area where it can supply almost 80% of the left ventricle. So even something goes wrong, definitely it will not forgive, because the patient can have a crash. So the long-term result should be better. So that's the reason always use the image edge dissection. Is there, are you falling in a plaque-free zone or not, or minimal plaque burden? These are all important. Even I was particularly calcified wells, many times the catheter will not track very well. With the OCT, if you push, the light source is gone. So it's a 65,000 rupees catheter. Definitely in such case, IVAS is more. Even if you push, there is no damage to the catheter. So that's the reason in such cases, very difficult in traveling, unless you are experienced, like using the guideliner, through the guideliner pushing, or pull the wire and buddy wire, use the wire and catheter together, you can push. So these techniques are very, very important, but use some imaging, because the OCT recent one, but most of the data is supportive of the IVAS.
Just one last question, Dr. Kasturi. In-stent restenosis and stent thrombosis, which is the appropriate imaging therapy to identify among these?
No, guidelines definitely mentioned OCT scores over the IVAS, because you should know what is the etiology behind the stent. It can show the fracture very nicely, any missing link, any gap. It can show what type of, is it neo-intimal proliferation? Is it neoatherosclerosis? If it's neoatherosclerosis, it can also show very clearly is a lipid-rich intima or it's calcific intima. And at the same time, underexpansion, it shows very clearly. And it also very clearly shows the proximal edge restenosis. Is it because the atherosclerotic progression, everything? So the most important thing is the SKY recently has mentioned the consensus document and management of the ISR based on the imaging. There, the Walkman's classification clearly shows if there is a gap between the stent struts, put the additional stent. If there is a neoatherosclerosis or neolymphedema, if the calcium is there, like you can do the plaque modification device, stent it. If it's lipid rich, you can stent it. Suppose under expansion, you can use the NCR DEB. If the edge resection because of the atherosclerosis, you can cover with the additional stent. So based upon the etiology, you can show very clear, like a stent thrombosis. There are various causes of stent thrombosis. Is it because of the malopposition? Is it because of the unhealed stent struts? Or sometimes they may have a bridges between the stent struts, across the stent strut. That can also cause. Sometimes they may have a finger-like projections between the stent struts, evaginations, these are called. These will become a nidus for thrombus. So you can see very clearly what is the cause of the stent thrombus, and if you treat accordingly, then results will be better. So before doing any procedure, always read it well, understand well, and accordingly you treat it well. Whether the patient requires simple NC balloon dilatation, or patient requires DEB balloon dilatation, or additional stenting is required, or any plaque modification is required. So compared to the IVAS, OCT is far ahead. It can show very clearly the etiology of the neoatherosclerosis. It can show, is it because of the neo-intimal proliferation.
Thank you, sir. Yeah. In fact, Dr. Ashok sir has joined, I think. Sir, would you like to, I think we are almost at the terminal end of the program. Sir, would you like to have your views before we sign off, sir? Look forward for your comments.
I just joined in because I had another call, which I just finished. But I was just catching on to Dr. Kasturi's comments. I think he's an expert at not just intervention, but imaging in a major way. So I think his comments were absolutely correct. I mean,
Sir, you have to unmute, sir.
Sir, you have to unmute, sir.
I think the message you gave was correct. Whichever methodology used, and by the way, the only point you must remember is that long-term prognosis and outcomes has been linked to IVUS, have been associated with IVUS imaging. That has been shown on large databases, including the BSIS registry. It's also been shown in many other follow-up studies. The dimensions and the MSAs are IVUS related, which have been correlated with outcomes, not yet with OCT. Having said that, do it well, use imaging properly. Remember that the biggest killer is malapposition, and that's the most important aspect that you look at. MSAs you will still get, but malapposition in all areas is a very important aspect. And therefore, MSAs, malapposition are two important things in mind, but malapposition more than MSAs, to tell you frankly. So I think use the imaging well, whichever you do, however you do it. Yeah. I think there's one thing very important which has always been missed out, choice of stents. And we must remember that the discrepancy between the daughter vessels and the left main can be so used sometimes that unless you understand choice of stents, you may not actually get the best and the most optimal results. And I say that not because some stents cannot be expanded by only 0.75 millimeter. For example, you take a 4, it can only go to 4.75. Every stent can be expanded by 1.5 millimeters more than its nominal dimension. The issue becomes that if it's not recommended to expand them, then what's happening is that you'll get the radial strength. The stents, the links will open up, the connectors may actually just broaden up. It gives you great radial strength, but you lose total control on drug diffusion and polymer leaching. And that's the main issue around it. So the issue is not that it won't get opposed, it will get opposed, you can oppose anything, but you then have unpredictability in its drug delivery and polymer leaching. Those are the things you've got to keep in mind when over-expanding stents beyond their recognized limits.
Yeah, so I think these are some of the great pearls which we keep hearing from Dr. Seth. So I'm more proponent towards OCT usage rather than IVUS. But yes, there are some areas where IVUS is more handy in left main osteal things, and where the kidney dysfunction is there, you can't use the contrast. So in that case, IVUS, is quite good, but OCT definitely resolution wise and gives you more clarity about the things. So that's another thing which comes into the discussion. Yeah. So
absolutely agree. Are there any other questions? I think I thought I was just listening in. I don't want to continue to comment. I was more interested in listening.
If you talk, we learn more. We always love to listen to you because your great wisdom always teaches all of us.
I think once Dr. Seth is here, we can just have a few more discussion points regarding the IVL balloon. So Dr. Seth mentioned it's a semi-compliant balloon. We go to 4 atmosphere. In my experience, I had 1 or 2 ruptures of this balloon also. Yeah. So that is one area where we have to be careful, and keep checking that whether it is inflated. At times what happens, we have inflated the balloon at 4 atmospheres and then start giving the pulses. And if it ruptures in between, we don't realize we're still giving pulses, and that may create these air embolisms and complications. So we have to be all the time, keeping our eyes stuck on the monitor with the inflated balloon. And this guy, the technician who's inflating with the inflation device, should be also all the time having the eyes on the inflation device, whether it's not retracting it's there. So these are small things are very important. But yes, let's have it from Dr. Seth that how we can actually circumvent this problem.
So Rajneesh, I've been a great expert at rupturing balloons, I must tell you. I'm one of the experts at that, and they'll tell you, Translumina tell you that I've had three meetings, and I've not had ruptures since. So here are the issues around it, and I've had great meeting with the scientists of Shockwave. The ruptures are for reasons clearly, and the reason I say that is I ruptured practically 8 balloons in my first 35 cases. So here it is. Ruptures occur if you fire on under-expanded balloons. So that's why I keep saying 90% stenosis and longer stenosis, and you get your balloon across, you push it across, and you say, now I'm going to fire. You have a higher chances of rupture because it's firing on balloon material. Secondly, if you shove it through heavily calcified lesions, which are underdilated, again, those are scratches on the balloon, and they've been actually seen on electron microscopy as weakened areas. Remember that after all, the balloon has to withstand extremely high pressures, not permanent pressures. These are momentarily pressures, but they're pretty high pressures of 50 atmospheres. Finally, if you don't give that saline enough time to cool, which means the saline contrast mixture, which means you withdraw it well, and it goes into the in-deflator, and that's why you're giving that 20 seconds also, and you get it back. If it's too heated, then it'll cause ruptures. Now we're not going to see a lot of ruptures. Once I started doing and overcoming these issues, I don't see a rupture at all. But going forwards, you don't have to worry so much. The balloon material is now changed. For the very reason, the balloon material is now thicker. So that new catheter came out in January this year with thicker balloon material. It's double balloon material, which has increased the profile from 035 to 036. However, that's the one which was used in the CAD study, and therefore that is the catheter, the new catheter. It's still called this modified C2 catheter, is the one which is approved in the United States, has approval in Europe now. And by the way, in a week or 2 weeks, whatever you're going to see, including the one going to be used for the 1,000 patients shock India registry, is the modified C2 catheter. So the thin-walled balloon catheter is now passed, and we're not going to see leaks and ruptures anymore. Ruptures have actually been known to cause dissections, even in my practice, where vessels have actually dissected forward and backwards, requiring more stents. And that is why, but I've been able to get over them by modification of technique in the previous generation of catheters.
Yeah, another important step, which is quite important while preparing the IVL balloon, is you have to absolutely de-air it. So if there is some air left in the system, that also is impediment for functioning of the balloon, giving the good shock waves, and we may face problems with that.
Yeah. Now you must also remember, and I'm just saying this to everybody, you will see gas formation in your balloons as you give the pulses. That's one of the mechanisms, as you know, bubbles form. The negative pressure for the 20 seconds will get those bubbles out. You will see that. And that is why it's never good to have an extension tubing attached to your in-deflator, a long extension tubing, because that never gets bubbles out. It's your short extension tubings which come with the in-deflator, which get attacked directly. That does mean that you've got to use a new in-deflator every time for a shock wave, but it sucks the gas out each time. And you're right, it's very important the gas not to be there, but the gas will accumulate every time the pulses fire, because that's the mechanism. But the gas has to be got out also by 20 seconds of sucking the in-deflator.
Yeah. So these are some of the good steps, and good discussions bring in more efficiency, and that's the reason we are all here in this session. And I'm pretty confident that this was very productive for everybody whosoever was here listening to this. And if you all permit, can we call it a day?
Yeah. Yes.
Thank you, sir. Thank you. Thank you very much. On behalf of entire Translumina team, we take this opportunity to thank you all to take out your valuable time and be part of this great faculty. I think the world of internet has really helped us, and this platform has really helped us. That today, getting this kind of faculty is so difficult when you have to bring it physically. But we were very lucky to have all of you. Thank you very much. We had 750 viewers for the evening today, in spite of the fact that there are a lot of parallel meeting going on. Thank you, sir, to have this. Thank you very much as we sign off, sir.
Thank you.
Thank you.
Thank you, everyone.
Thank you all. Thank you.
Shulovin.